Good morning to all of you. So I'm Anne-Claude Lefebvre. So I'm the director of Biotech Santé Bretagne, which is the Technology Innovation Center and the Health Cluster in Bretagne. And we are also happy to be involved in this nice intensive project with most of you. So my colleague Adeline and I are very pleased to welcome you today for this online study visit within this intensive project. Of course, even if it's much less user-friendly than a real face-to-face meeting, and we would have enjoyed welcoming you in the city of Rennes instead of this online study visit. But I'm sure we will spend nice time and have nice discussions today. So Adeline made a great job organizing this study visit, and I will let her give more information about the agenda of the day. And I wish all of you a nice day and with fruitful discussions. And personally, I will be back this afternoon for the presentation of the e-health ecosystem in Bretagne. So Adeline, it's you.
Thank you, Anne-Claude. Good morning, everybody. We are very pleased to welcome you today for this intensive day. Before entering into the different topics we have today, I will say a few words for those of you who are not partners involved in the project every day. Just a few words on the intensive project, what it is, who are we, and then I will tell a little bit more about the program of the day and about practical rules for this session. So, what is intensive project? So I will share with you a few slides, if I can. Okay. Well, okay. Intensive is a collaboration project between 5 regions, which goal is to transfer good practices between partners and the different partners involved within the project. Its aims is to implement what we learn from each other and at the end to establish an action plan. So who are we? 6 partners from 5 different European regions. So in Finland, we have our coordinator, who is the Regional Council of South Ostrobonia, plus another university partner, Senat Joki University of Applied Sciences. In Hungary, we have Panan Business Network Association. In Malta, we have the Ministry of Gozo, who is a partner. For France, that's Biotech Santé Bretagne. And in Spain, we have Valdecilla Biomedical Research Institute, also involved within the project. Slides are a bit slow, sorry. Just takes. Okay. So what are the objectives of the project? First of all, it is to improve the implementation of the different policies and programs in terms of e-health sector. And the project has a customer orientation in the center of the project. So this is really important for us to analyze the needs of the customer. This is really the key element of the project. The objective is also to influence to the end the regional operational programs or the regional strategies in order to improve them and implement other policies in this field. So what about activities? We have 50 good practices collect, which is done throughout this project. Each partner has to find 10 good practices to identify and to analyze in his own region. For Brittany, we retain 11 good practices. And so within the project, we have an evaluation process of these good practices thanks to the modified Big Bang model analysis. So the objective is to exchange good practices between the different partners and to enrich each partner's practice and policies. And then we also have some study visits and workshop online organized in order to share these different practices. And at the end, we have to establish some actions plan within our regions in order to implement these different policies and good practices. So what is the program of the day? So today, of course, in link with the COVID situation, we were not, unfortunately, able to welcome you in person. So we organized this virtual study visit in order to present 4 good practices of our territory. At the beginning, we will have a presentation of 2 of our stakeholders which are involved into this project and following the project at the regional level here in Brittany. So the Région Bretagne and GCS e-Santé Bretagne, which are very important key actors in these fields. Then we will present 4 good practices of our territory. e-KerMed, first for the regional portal for telemedicine offer. Then we will have a presentation on the Pôle St Hélier and with his experience on telemedicine for chronic wounds. We will then have a presentation of the REHAB-LAB Kerpape Rehabilitation Center, who will talk about the way they use 3D printing in order to create assistive devices. And we will finally finish this morning session with VIGILANS and Sys-vision application, which is a system following persons who try to suicide themselves in order to follow them in a very practical and good way for not redoing the same thing. So just a few practical rules for this morning session. I would say for the questions, as we have quite a lot of speakers and we have to, well, try to respect the different time slots for everybody. Please, if you have any questions, feel free to ask them within the chat session, and we will collect them. And after each session, each speaker, we will have a few minutes for taking the questions and asking them to the speaker. Please just precise to which speaker the questions are addressed so that we can properly organize them. And so then we'll have the different presentations with about 20 minutes for each lecture and 5 minutes of questions each time. And in order to make it a little bit more living, we'll have a few videos to show you before each presentation. So now, in order to just give you the taste to come back to Brittany, as we could not welcome you in person, we will put you a small video of Brittany to show you our region, and we hope that it will give you a taste to come and visit us maybe later in the project, we hope. Okay, so after this presentation of the region, I will now give the floor to the region of Bretagne, Brittany Regional Council, with Mathilde Luna, who is Head of Projects in Health Regional Policy, and who will present you the role of the region in the field of health and innovation. Mathilde, the floor is yours.
Okay, good morning, everyone. I'm Mathilde Luna. I'm in charge of regional health policy at the Regional Council of Brittany. I'm delighted to be with you this morning with my colleague Anne-Laure. Anne-Laure, do you want to introduce yourself in a few words before I begin?
Why not? I'm Anne-Laure Baudrier. I'm a project manager in innovation at the Regional Council of Brittany. So I work in the innovation service. So we are two people today to speak about Brittany's Regional Council policies. Mathilde.
Thank you, Anne-Laure. Before our presentation, I'm going to start introducing the Regional Council of Brittany and its health policy, but I don't have the slides. Maybe.
You got the hand, Mathilde, on the PowerPoint normally?
No, I can't see it.
You can see it?
No.
Just a second. We'll just.
I have a program of the day.
Okay. So and then you can pass the switch the next slide.
Okay.
Normally.
I can try.
But it just takes a few seconds when you push one time.
Yes.
Okay.
Okay. Sorry.
That's fine.
Okay, that's good. So for the context, France is divided into 13 regions, and each region is administered by a regional council, which has some responsibilities, like in economic development, space planning, transport, high school buildings, for example. And the regional council is governed by a president and an assembly. In Brittany, we have 83 members in our assembly. Okay. About health policies, in France, health policies are within the competencies of the state. Local authorities like region don't have competencies in health. For each French region, there is a regional health agency, which is responsible for enforcing best national policies according to regional specificities, but they are state agencies. Some responsibilities can be delegated to local authorities, such as social and healthcare training, for example, which are delegated to regions. But regions can act for health by other policies, like, for example, economic development that can support innovation. And Anne-Laure will precise it later. In Brittany, the Regional Council made the choice to have a voluntary health policy. That policy was renewed in 2017, and this policy is complementary to the national one. For example, we have some actions in promotion of youth health. We support peer-to-peer prevention, risk reduction in festival, but some examples of our actions. We act also for the development of a primary healthcare offer, and in this aim we can support some projects in e-health. But we have only a few projects in e-health. We sign, Regional Council signs the contracts with local authorities for local health development. There are a few contracts in Brittany between local authorities, regional agencies, and a lot of partners like the Regional Council. We also support the regional health observation because we need data to decide of our actions. And we have an engagement in the regional plan for health and environment. But we pilot with the state and the health agency in Brittany. Okay, now Anne-Laure is going to talk about our action in the field of innovation.
Yeah, to speak about innovation, some key figures to begin with. The region has been ranked as strong in Regional Innovation Scoreboard published in 2019 by European Commission, and that is relying on a strong ecosystem like One Society for the acceleration of technology transfer, One Technology Research Institute, some 15 innovation platforms and centers such as Biotech Santé Bretagne, 7 competitiveness clusters and 7 technopoles. I think ALLEGRE will present more about the ecosystem this afternoon. In the field of health, we count more than 1,500 medical social institutions and more than 500 companies in the field of health in general. You can, next slide, Mathilde. We've worked new smart specialization strategy this year. You may not be aware of what is a smart specialization strategy. That is a strategy highlighting strongness, assets and opportunities for the region in the field of research and innovation. So that's the map of what you see is the project. It has not been voted by our about the regional council yet, but it's programmed for December. So this is confidential for now. This strategy relies on 5 pillars, which are innovation, strategic innovation areas. 5 of them, among which you can see in red the health and welfare economics for better quality of life, with 6 topics. And first of them is health technology. So we are on the topic today. 5 pillars and one crosswise pillar about transitions that are ecological transition, social transition, and digital and industrial transitions. So this is the map for 21-27. Next slide. Region Council's innovation policy is about 2 lines. First of it is to encourage an environment conducive to innovation. That are operators who guide the emergence and the structuration of innovative projects, working with the regional agency and in the light of the S3, Smart Specialization Strategy. And second is to support innovative projects. So there is the environment, the operators first and the project second, and this is not a rank, so it can be first project and then operators. So to support innovative projects from research to business, from business to research with a collaborative project, to support incubation and emergence of startups, and we are lots of startups in e-health for the past decade, and to support innovative projects of product, processes, services by companies in partnership with BPI France Brittany, which is the public bank of investment. Next, and to do that, we have many tools to finance the continuum for the emergence of startups and for innovative projects of SMEs. We use grants, we use honor loans, public equity, and refundable advances. Next. And I wanted to highlight some examples of finance projects. I think Anne-Claude will tell you more on many of them this afternoon, so I will be brief. We can quote the Call of Projects Digital Experimentation, launched since 2016. This year is the 7th edition. We have 2 per year. Several projects at the crossroads of digital companies and medical social establishments, such as Hospiville between MAPFRE Labs and Hospital of Kerpape, X-Curity between Curity and Hospital of Rennes, or Ozo AI between the startup Ozo AI in Brest and Ildis Foundation, which is a nursing home. So we have many different kind of projects. I wanted to highlight as well the Handicap Innovation Territory project, which has an important digital side with Artefacto or Become, for instance, and the Connectathon, an event, I don't know if I pronounce it right, an event held in Rennes last year. Next, Mathilde, for you, your turn. Okay. To finish, I would like to precise our engagement in the intensive project and the interest of the regional council for it. Because as Anne-Laure said, digital health is a key stake in Brittany. We are a dynamic region for e-health innovations, but those are little used in the region and in France, even if it's increased with pandemic. Intensive, we expect that this project will speed up the use of e-health and the development of innovations in this sector. And Renaud will after present all the projects in e-health in Brittany we have actually. And for us, the objective is also to increase our knowledge about Britain experiences and also your experiences in Europe to have other practices later. And the next and last, I think. Sorry. In the actual ERDF operational program, we committed to 15 million euros to enhance digital use in different fields, and especially in e-health. The aim was to support regional projects, but also local projects. And the intensive project is for us an opportunity to adapt our action and goals for the next program to have more projects in e-health in Brittany.
And in the Project Intensive, we support Biotech Santé Bretagne, linking them with Britain local authorities and project leaders in e-health. We gave some contacts to identify good practices, and we help them to select good practices for the project. Some elected people in the regional council will be interviewed for the project and to select good practices and to adapt to understand and adapt after policies in favor of e-health. And to finish, we expect to consider recommendation that you will do to adapt our policies and in the aim of increase e-health use. I hope it was clear. And we thank you very much for your attention.
Thank you, Mathilde. Thank you, Anne-Laure, for your presentations. I would maybe, we don't have questions for the moment, but I would maybe just have a small question. At EU level, do you know if you have any cooperation agreements with some other European regions in EU at the regional council level? In
the field of health?
No, yes, in the field of health, but also maybe more largely, just usually have some.
In the field of health, I don't think so. I think we rely on Biotech Santé Bretagne to do so. The regional council, I think, is partner of different projects, at least in the economic development area, in the field of renewable marine energy, for instance. I don't know if it's the English word.
Yes.
Or yeah, okay. In the field of hydrogen as well, I think.
Sorry, of what?
Hydrogen.
Hydrogen. Yeah. Okay. Thank you.
I can't think, but there are in the field of cyber, of course.
Mm-hmm. Okay.
For the other areas, I don't know.
Yeah, I think we have a lot of cooperation at the European level, but not in the field of health.
Okay.
The intensive project is the only project we are partner with.
Thank you. So maybe now we'll give the floor to the next speaker, to Renaud LEFEVRE, who is Director of GCS e-Santé here in Brittany, and he will tell you more about the role of GCS in the field of e-health policies. So Renaud, the floor is yours.
Yes, thank you very much. You hear me? Yes, it's okay for everybody. Yes, good morning, everyone. I'm Renaud LEFEVRE, the director of the GCS e-Santé Bretagne. I'm very happy to be here. I will present the GCS to you, and just at the end, the focus on the telemedicine offer e-KerMed. Why, next Elodie, please. Why GCS e-Santé Bretagne? GCS means Health Cooperation Group, or a synonym, Regional Group for Development of e-Health. In 2007, therefore 13 years of existence, to face the new challenges of digital health, all health actors like hospital federation, representatives of the role of private medicine, and the REHAB-LAB, the regional health agency, which to equip themselves with a structure to answer the operational deployment of e-health project in Brittany. In France, E-health is strategically regulated at the national level by ANS, the National Agency for Digital Health, then at the regional level by the IRS, because each region may have its own priorities depending on its territory in relation to the national guidelines, of course. For example, in Brittany, we have some islands. Of course, the first project for telemedicine was island telemedicine. The GCS is a private non-profit organization for health actors in Brittany, and we have more than 200 members in the GCS. Daily challenge for us, the GCS, is to increase the use of e-health. It's very important for us, this challenge every day. Next, the role of the GCS e-Santé Bretagne. The GCS can support deployment of national.
Excuse me, it's a bit complicated to switch the slide, so there is like
it takes a few seconds. Yes, sorry.
I'm sorry, but
yeah, it takes a few seconds when you push on the arrow to pass the slide. So you just have to wait and do that push.
I'm waiting, but
several times. Sorry about that.
Yes, it's not easy. Sorry for the technique, but yeah, I'm waiting.
Normally, yeah, you have the end. Sorry about that.
I don't want to push a lot because
yeah, it's
slide. I'm sorry, but yeah,
there are some problems. You can switch.
Nothing is moving on my screen.
So. Sinon, on transfère nous. We can try to. More? Okay. So sorry, I can have the hand on it if you want, but do you want to go before or after the slide? Sorry.
No, the slide we need is like what offers GCS e-Santé Bretagne.
Just the next slide.
The next.
Okay. Okay. So normally I passed it. Sorry. That should come.
Sorry for this.
But it depends on the network, so sorry because it can be quite slow sometimes. Yeah, well, Roxanne will do it. Roxanne? Okay, it passed. Yes. Sorry. Sorry.
What is the role of GCS e-Santé Bretagne? The GCS can support the deployment of national projects and support the project of its members. As soon as health professionals wish to exchange or share for the benefits of the patient, the GCS can operate whether in piloting or in project coordination. The GCS has a role of project management on its projects. There is no developer, no geek inside the GCS, and we call numeric actors to develop digital solutions. Also, GCS promotes a portfolio of service anymore. Next.
Okay.
Yeah. Right. Nice. What proposes GCS e-Santé Bretagne? Our members are from the biggest hospital in Rennes or in Brest to private medical practice, including older persons and disabled person places, startups, and patients. GCS acts for all the kinds of health and numeric actors to serve the patient. It's our objective. For example, 4 tools or services. Mobility by globule, mobile secure application to facilitate coordination between multi-health professionals, doctors, nurses, pharmacy, physiotherapists, on the basis of sharing a liaison book instead of the school notebook or post-it in the patient's room. Messagerie sécurisée de santé, secure messaging permits to exchange health data in a secure way to the good health professional. Gwelen is a tool to facilitate the healthcare for patients in complex situations, or e-KerMed for the regional telemedicine offer, which be the subjects later. We use Breton words, T, care, Gwelen. Gwelen is a care team in Breton. e-KerMed, care for house or mobility, TY for home, inside the different name of the services. Next. Alors, why the GCS is Projet Intencive project? Donc, the C letter in GCS stands for cooperation, and this is a very strong concept for us, and cooperation with all the actors of e-health and the patient. Project manager in GCS are very focused in organizational innovation and change management. It seemed very important to me to be able to exchange of good practices from other countries, to share about e-health and innovation, or to evaluate our practices with the different actors, different European actors. Sorry. Also, it was important through the big VAR methodology, which puts the users at the heart of the evaluation, to participate to this evaluation method. Next, now a light focus about our tools, our tool for telemedicine service offers. Since 2013, we have been working on uses around telemedicine. At the start, we deployed a telemedicine platform, Star, in Britain. After 5 years of use, this platform could be seen as a break on the uses of telemedicine. Indeed, this platform could make apart heavy, very complex to use, with a dedicated PC, with dedicating rooms to practice telemedicine, and the world platform for the professional could scare users also. The new approach with e-KerMed was to offer a new service in a simpler and more affordable way. Telemedicine is now possible with a phone, with a tablet, in mobility. And so the users could use their every tools to practice telemedicine. And to finish, like a neutral actor, the GCS guarantees to have a neutral choice and neutral advices. Just before continuing to the video and presentation of Dr. Marikos, some key facts. Since the beginning of the year, more than 3,000 users accounts created. There are users we have made a teleconsultation at least once. More than 40 hours of teleconsultation, and more than 20,000 teleconsultations carried out. It must be seen that despite the negative impact of everyone, COVID virus has been a rare accelerator of telemedicine, and it allows us to win several months or years with these new professional practices. Just before COVID, up to 20-30 teleconsultation per day. In March or April, we have more than 1,000 teleconsultation per day. And now we have 500 active users who practice every day the teleconsultation. Thank you very much. I let Adeline start the video.
Okay, thank you, Renaud, for your presentation. Yes, now we will pass you a video for presenting e-KerMed, and then we'll have Marie Costa making her presentation.
e-KerMed, les solutions de télémédecine proposées par l'ARS Bretagne et le GCS e-Santé Bretagne. Dr Merlin est le médecin traitant de Madame Corrigan, résidente d'un EHPAD en campagne. Madame Corrigan a besoin de consulter un dermatologue pour une lésion suspecte sur la poitrine. Madame Corrigan a des difficultés à se déplacer et les déplacements sont très déstabilisants pour elle. Dr Merlin lui propose donc de faire une téléconsultation. Il se rend sur e-KerMed.bzh, l'annuaire des offres de télémédecine en Bretagne. Il trouve une offre de téléconsultation en dermatologie à 30 km de l'EHPAD. Par messagerie sécurisée, il transmet au dermatologue le dossier du patient et prend rendez-vous. Quelques jours avant la téléconsultation, il reçoit le lien qui permettra au dermatologue de communiquer avec Madame Corrigan. Madame Corrigan, accompagnée du docteur Merlin, bénéficie de sa téléconsultation en restant à l'EHPAD. Dr Merlin reçoit le compte-rendu de la téléconsultation ainsi que la prescription médicamenteuse sur sa messagerie sécurisée. Vous souhaitez démarrer une activité de télémédecine ? Projet médical, organisation, responsabilité, matériel, solutions, le GCS e-Santé Bretagne vous accompagne dans la mise en place de votre activité.
So now I will let Marie Costa, who is a medical coordinator of telemedicine at Rennes University Hospital, make the presentation of the tool e-KerMed. Marie, the floor is yours. So you have the hand on the slide.
Do you hear me now?
Yes, that's better.
Okay. Okay. So my name is Marie Coste, and I'm a doctor at the University Hospital in Rennes. I work in Geriatrics, and I'm involved in telemedicine projects since 2016 now. So thank you for letting me presenting that work and e-KerMed, which is the e-health and teleconsultation service, as we just said, carried by Brittany Regional Health Council and GCS. So next. So I pass the slide, or it's you?
Normally it's you, but if you prefer, we can do it.
I try.
It's very slow, so just sorry, it takes a few seconds sometimes.
So maybe it's easier if you do it.
Okay, I can. We'll take the hand. Roxanne,
It's faster, isn't it?
Roxanne is going to pass it. Yeah, sorry. Okay.
Yeah. So as Renaud LEFEVRE just said about the regulation on telemedicine, for us in the region, the key date is 2018, because from 2010, France we started having a regulation about telemedicine, and then in the region we started working on it in 2013, and the first teleconsultation program in 2014. And we've been working on, as we've just said, a quite heavy platform and lots of settings and system configuration, which was quite hard to get patients and new professionals on the platform. So that was mainly at that time health institution and hospital who could use it. And we, in Brittany, we had the chance to have a very dynamic steering committee with the involved medical members. And we had that reflection on needs in the fields. And we thought we needed to practice telemedicine with everyday life tools. And there was needed also for mobility and to be able to propose teleconsultation for patient at home and everywhere without a limit. So what we did is to work on deconstruction of an act of telemedicine, because at that time we had to renew the contract with the platform, and that was the occasion to work together about the act of telemedicine. So next slide.
Okay. Roxanne? Yeah. Okay.
So we discuss about the teleconsultation process, and the first need identified at that time is the medical need. So we're based on the medical need, because telemedicine is medicine first, and so the need of a patient and the need of a health practitioner. So we thought we have to put in contact health practitioner and specialist or a GP. And for that, we thought we need to give information, and that's how e-KerMed came with a list of contact. That's the first step. Then we need to exchange medical information in a secured way, like a referral letter, X-ray, or whatever exam. And we had the secured email for that, which was not very much developed in the territory. So that was a good way to implement that good practice using secured email and messaging for medical information. Then the next step is to book an appointment and to be able to every doctor to do teleconsultation using their regular tool for appointment was easier. We thought it was easier. Then we needed a specific and secure tool for video conference, medical video conference, and that is one need addressed with e-KerMed. Then the medical report and prescription, as we just said, seen in the little video. So we preconize to use a regular patient record and software. So every kind of doctor use their own software. And of course, at the end, the billing and online payment, which was important, especially for private doctors, to be paid. And so we needed also billing online. Next. And based on that, to cover the 4 needs uncovered at that time, we thought to create e-KerMed, which is 4 services for all users. So the first step is information, then exchange medical information, the video conference, and the support. The next slide, please. So that's the first environment of e-KerMed, which is the sharing of information and the list of professional and contact practitioner. So you have one part in the e-KerMed website about all regulation and information about telemedicine generally, because health care professionals are not very, it's not in the culture. All the numeric and numeric tool is not really in the culture. So people have a lot of questions usually, and they have all the answers in the website. And also they can if they need teleconsultation, they have all the list of contacts. So there is a description of the offer and the modality of taking appointment and how to do it. Next. Then, as I said, using the secured email was important to improve and the use of that kind of exchange. And GCS e-Santé can provide a secured email for doctors and nurses. Next. So the key point is about the medical video conference, which was the biggest part of work, with the collaboration between doctors and the GCS to find the best way of medical video conference. So next. The slide is okay. It's okay. So first, no, can you go back? The first important thing was, of course, encrypted and secured video conferences, because we exchange medical data. Also, it was important for us to be able to use it on all devices, because the medical practicing can be various in a virus environment. So we needed very light thing like smartphone or tablets for people at home, but also something if you are in an institution and if the patient has a teleconsultation with the nurse or health nurse, for example, in a room, so you can have a bigger device. Of course, no settings, and also no personal account for the patient, which is important because we want to be able to do teleconsultation with all kind of patients, disabled, old people, non-technophile people. So that was an important to not being mandatory to create a personal account. No training, something very easy to use. We also thought of a virtual waiting room, so the patient is know when he gets to the waiting room and when he gets in contact with the doctor, so he's not lost in the internet when he connects to the doctor for his teleconsultation. And the last thing is online payment, which is needed for like private doctors for outpatients. So we put together all the needs for all the different practice. The last step was the support, and GCS offer support for all kind of practitioners, nurses, doctors, or nursing home, hospital, and they give advices on the organization, how to lead a project, a telemedicine project. Support also on hardware devices regarding what kind of practice you want to have. Information about internet network, because as I said, in the health culture, we are not very, we have no training on internet networks and all that kind of thing. So GCS is a good advisor, offering training as well, and advices on the regulation matter. So people are aware of all that when they want to start a telemedicine project. Next. So the outcome of the strategy is very interesting now, where we are, because we had a strong increase of uses in every field, like private GP, nurses, nursing home, hospital. Everybody is able to use e-KerMed very easily, and that's one of the best points we have today. Of course, all that evolution has been helped by evolution of French regulation as well, because now teleconsultation is fully reimbursed by the national health system. And also the COVID health crisis, of course, was a booster of the use of e-KerMed. So as I said, all the sectors can now offer teleconsultation. So in our experience in my field of geriatric field, to give you an example, when we started in 2014, we started with 2 local hospitals that we were working with. And now in 2020, we work with 35 nursing homes. We're in contact to provide teleconsultation for that fragile patient with all kind of advice in geriatric, in dermatology, chronic wounds, and other field of re-education and everything. So that is a big development. Of course, we still have a further reflection on e-KerMed because we're still working to enhance tools in that strategy of simplify software and uses of devices. Also, we have a discussion to implement and ease expertise and the net expertise. So we keep going and working on the regional e-health architecting, always based on patients and practitioner real life needs. So thank you for your attention.
Thank you, Marie, for this very interesting presentation on e-KerMed. Just checking, well, for the moment we don't have any questions. So I suggest that we will continue on the experience of Pôle St Hélier on telemedicine practice, and we will pass a video before letting Dr. Sandrine Robineau presenting the activity of Pôle St Hélier in this field.
Est-ce qu'il y a eu des événements particuliers sur le plan médical, sur le plan général, depuis la dernière fois qu'on s'est vu?
La télémédecine au Pôle St Hélier s'est inscrite dans un travail collaboratif au sein des équipes médicales et soignantes, en lien étroit avec les professionnels de santé sur le territoire, pour faire en sorte de permettre aux patients d'être suivis sur leur lieu de vie.
L'ambulatoire est un axe important et la télémédecine est un de ces axes, comme sont les équipes mobiles, l'HAD, l'hôpital de jour.
Ça permet aux patients d'avoir cette offre de soins pluriels en assurant son maintien au domicile. C'est rassurant aussi pour l'équipe soignante qui encadre le patient à domicile d'avoir ce lien avec l'équipe experte, et c'est toute la plus-value aussi de cette consultation qui devient pluridisciplinaire en y associant le patient.
On veut vraiment vous récupérer justement cette cheville qui est bloquée.
Bah oui.
Bénéfice pour le patient et bien sûr aussi pour nous soignants. Par cette cohésion d'équipe et cette discussion pluriprofessionnelle, on peut obtenir un discours commun et un projet de soins commun pour notre patient.
Et c'est vrai que je suis quand même contente d'avoir essayé la télémédecine, quoi. Ça évite de se déplacer. C'est vrai que c'est bien pour ça.
La télémédecine représente un véritable trait d'union entre l'hôpital et les professionnels qui, eux, se trouvent en ville ou au plus proche effectivement du domicile. Donc c'est un service supplémentaire.
Qu'est-ce que vous prenez au petit déjeuner?
Donc il faut que le petit déjeuner soit un vrai repas. C'est très important.
Il faut que les outils qui sont utilisés soient les outils du quotidien. Les smartphones, les tablettes, les ordinateurs classiques. De telle sorte que l'on va pouvoir développer ce type de prise en charge en le démocratisant.
On est plus en contact avec les professionnels, plus en contact avec les patients directement. On appelle ça une organisation apprenante. Ça permet aussi, par ces techniques, de favoriser l'apprentissage, les connaissances et les compétences.
En fait, cette partie-là n'existait pas. La télémédecine nous a permis de rencontrer des professionnels qui nous aident pour l'encadrement du soin et du pansement complexe. Ça nous oriente vers des nouvelles choses et en même temps, ça nous conforte dans ce qu'on faisait déjà d'avant.
Il faut que là, ça soit le même.
Ah bah oui, ce soit, bah oui.
La télémédecine est un outil très intéressant pour améliorer l'alliance thérapeutique. Parce qu'il y a un temps d'échange entre lui, le professionnel de santé qui l'accompagne au domicile et l'expert. Et ça, c'est un vrai changement de paradigme aussi pour l'équipe médicale, c'est-à-dire de dire le soin, on va maintenant l'apporter chez vous.
Hello? Do you hear me? Sorry. Attends. Sorry, can you hear or listen or see the image?
Yes, we hear you.
Okay. And did you see properly? Yes, I hear you. Did you see properly the video? Because
yeah.
Okay, good. Because it seemed to be a little bit stuck on our side. Sorry. Okay, perfect. So now I'm going to leave the floor to Dr. Sandrine Robineau, who is PMR Neurology and coordinator of Telemedicine at Pôle St Hélier in Rennes. Dr. Robineau, we'll pass the PowerPoint,
yes,
and we'll give you. Yeah. Do you want us to pass the slides for you?
Yes.
Okay. We'll do so. Sorry for the technical trouble. Just a few seconds. It will come.
Okay, do you hear me?
We can hear you. That's good.
Okay. So thank you for inviting me. It's my pleasure to share with you our experience. Next slide, please. So I have no financial interest. Next. Okay, so I am Dr. Robineau. I work as a physiatrist in a rehabilitation center, Pôle St Hélier, which is located in Rennes, in Brittany, in France. Next. Just to introduce us, we have two parts. In the first part, in the PRM center, we have 120 beds divided in 3 neuro-rehabilitation units, including 8 beds of post-intensive care, including vascular and orthopedic unit. And since 20 years, we developed our outpatient care offer, such as mobile team, home-based hospitalization, and day hospital. And since the COVID course, we began a digital day hospital. On the other part, we have a nursing home with 100 beds. Our research unit works especially next, please, in the field of new technologies. And you can see on the slide the robotic tools that we use in the center, and some of our research projects in this field of robotics, serious games, telemedicine with connected glasses, for example. And you can see the Smart Wheelchair, which is a research European project too. Next. So what are we talking about today? the point was to know if telemedicine could be an answer to the pressure ulcer problem, to manage it for one part. It was our question in 2013 when we began. You can see on this slide that pressure ulcer is a skin injury when the soft tissue is compressed between a hard surface and the bony prominences. And you have to know that it's really a very big issue in the health public, because the prevalence is higher when the people is aging. We conducted 2 surveys in 2013 in Brittany to have a real knowledge of the prevalence in nursing homes, and the result is on the slide. And in the hospital in France, we know that it's about 8%, and the cost is very important per day of hospitalization. You can see on the right what is happening when the surface is hard, and during the COVID crisis, the prevalence of PU increased very much with the prone position in ICU units for COVID. So really, it's a health public issue, and our question was next, is telemedicine an answer for us? So that's why in July 2013, we responded to the call for project of the Regional Health Agency. Next. And it was our first step in the way to personalize the care pathway according to the person's needs. First, telemedicine for use, and after telemedicine for rehabilitation, and after the home-based hospitalization, and after the digital day hospital. And we have other projects for the next decade. And the goal is really to have the opportunity for people to make the right choice for them at the right moment. Next. So you can see the usual goals of telemedicine: improving care access, avoiding transport, enhancing comfort, bringing expertise at home. And some of them were not expected so much at the beginning, but now we can say that it's one of the real big important points of telemedicine. I mean, training at home and fostering therapeutic coalition, as you can see in the movie. Next. So the process is very simple, as told you Marie-Coste. First, there is a medical request that we validate in the center. After that, there is an appointment between the caregiver at home and us. And the day of the appointment, we begin the video conference with the secure video conference. And after that, it's like a usual medical consultation. We made a choice that the consultation is directed in first step by our nurses that are specialized in wounds. And after the day of consultation, we organize a meeting with the expert physicians specialized in wounds and the interprofessional staff that was involved in the teleconsultation of the day. So we use obviously day life devices like a smartphone, tablets, and a computer, but often it's smartphone and tablets. Next. So you can see the type of patients that we take care for. They had wounds that are very difficult to deal with, and they are often elderly, and they have often high level of disabilities. Next. Since the 2014, when we started, the results are very stable. In average, elderly people, half in nursing home, half at home. We carry out about 200 teleconsultations for wounds per year. 30% are new wounds, 70% are follow-ups, and our organization is 1 day reserved per week for the wounds, so for the teleconsultation for wounds. Other days are for the tele-rehabilitation. What is important is that in more than 25%, we include what we call teleassistance. That means that during the dressing of the wound at home, our nurse specialized in wound helps the professional at home to dress the wound with the right technical aspect. She learns, or he learns to her how to do the best way for the healing. And it's very important because it was one of the needed of the nurses when we asked them in 2013 during our with the survey. Tele-expertise for us is not so often used because we use it between 2 teleconsultations to monitor the progress, in fact. Next. Other results, we achieve our goals. It's very easy to have the appointment with our organization. The act is about 30 minutes, 20 minutes for the follow-up. And there is really a very big link between home and hospital. We make a bridge with them. And we can discuss about extra issues with GP, with nurses, with the natural caregiver about the assessment of the mattress, the cushion, the shoes that are important to relieve the pressures, the nutrition, and so on. As I said, it's a learning organization. I will focus on it. And of course, transport are avoided about 10,000 kilometers per year. Next. For us, telemedicine is really a key axis of outpatient care, and it is beginning to democratic because it's really easy. As Marika told you, it's everyday digital tools, and it's something different from the usual consultation. The goal is not to replace the usual consultation. It's really a collective work, and we built a bridge between home caregivers and hospital caregivers. And we didn't expect it so much when we started that point. It increases competencies because this learning organization is a free training at home, really. And that's an answer for the nurses at home because they are very alone when they have to manage a chronic wounds that never heal. And we saw an improvement in the care because there is a higher rate of recommendations that are applied, and there is no change in the treatment in 90% of the cases. And it's very important in chronic use because it is one of the problems, because nobody knows how to do with that. Nobody knows how to fix it, and everybody has an answer, a new answer each time they go to home. So the changement of treatment is one of the key of the chronic wound. So it's really a victory to apply the recommendation together. Next. That's what the caregivers told you in the movie. They feel less alone. The discourse is shared. It's live training. There is no waste of time for the nurse because we book the appointment during the time she or he is at home. So it's very easy for them. There is no transport for the patient. And what an important thing, moreover, is that the patient is welcoming us at home. It's different. It's a different way to communicate with the patient. He's very involved because he is in his own home. And it creates the therapeutic coalition, included the nurse, the patient, and the expert. Next. Here are the details of the satisfaction survey in the doctoral thesis. Nurses recommend telemedicine to their colleagues. They wanted to continue and they wanted to use it as a training way. Next. So just to finish, I would like to report this case of a woman, a young woman of 30 years old. She had a scooter accident, a broken leg, and unfortunately a surgical site infection, a chronic wound due to the bacteria, and her leg was very stiff. As you can see, just 70 degrees of knee flexion. So we proposed her to mix the home-based hospitalization with our physiatrist and occupational therapist, and the telemedicine for chronic wounds to heal the wound and to help her to be able to go to the swimming pool in the balneotherapy. Next. And the wound healed. Next. And this woman was a hairdresser, and she had her own hairdresser shop. And it was at the end of 2019, I remember, just before Christmas, and she wanted very much to go back to her work and to her shop at the beginning of the next year. It was really a challenge because she was not able to stay to stand up all the day. And we decided with her to try to find a workstation comfortable for her. And our occupational therapist went to her hairdresser shop with her to find a height adjustable chair for this comfortable working. And she decided to be back to her work just at the beginning of the 2019 years. And she was half-time at work and half-time in day hospital with the balneotherapy in the day hospital. Next. And with this personalized pathway, she could begin faster her work, and she was very happy with that. And I saw her this year during the holidays. She climbed mountains, and it's very important to adapt the pathway for the patients to their needs, their wishes, and the possibility of the care offers. So to sum up, we made choices, and we have 3 big axes. Telemedicine for chronic wounds is for us a part of our care offer directly at home. We built a collective work with this bridge between hospital and home caregivers. And we continue to use live trainings and teleassistance to increase the competencies of the nurses at home, and of course to improve the healing of the wounds. Thank you very much. Next.
Thank you, Dr. Robineau, for your presentation. I could see that while I did the evaluation process with part of your team who were involved in the telemedicine offer, that to what extent it was a very interesting tool in combining the different persons in the team with this useful tool. We have one question for you, and then we'll also be able to take another question that was previously for e-KerMed persons. So our question received is, it seems that telemedicine has worked very well with chronic wounds. What do you think is the most important factor that it has been so successful?
For us?
Yes.
I think it's the live training and the collective work, because in fact it's like if we created without wall care team. You see, it's a new team with the caregivers at home and experts in our hospital and the patient, and it's real different. It's another way to work together. It's not better than the hospitalization. Sometimes we need to hospitalize the patient, but if the patient could stay at home, and if the problem is the chronicity of the wound, we have to help caregivers at home to improve their healing. And the point is that they are very alone at home. I think that is one of the key success. We have now more than 100 partners in the area, in the Brittany.
Thank you for this. So I'm sorry, because we'll maybe also come back a little bit before and take one question that was for Marie-Coste and potentially Renaud. It was on the e-KerMed tool. So the question was, what have been the most challenging things with e-KerMed?
Yes. One of the most important challenges was for us in the GCS to support users to switch from Steren, the old platform, to e-KerMed, because we have a lot of users, to build new training materials. Therefore, in fact, to organize the change management finally, and finally to promote e-KerMed. And maybe Marie can complete with our experience at the hospital. Marie, t'entends pas?
On n'entend pas Marie.
Yeah, sorry, my microphone. So yeah, the challenge was to pass from one big platform, very to e-KerMed, which was a big challenge, and also practitioners were quite happy because the medical community could express, and the GCS was very open-minded to change the concept of practicing telemedicine, which was what we think is telemedicine is not something apart in the process of a medical path for patient, as Sandrine said just now, is just a new tool that we can use in any appropriate situation. And what we wanted is to include telemedicine, include teleconsultation in the patient path. And I think that's the challenge now. And in our hospital, we are thanks to also to the crisis, because we had to use teleconsultation and distance care. But now the challenge is to keep this practice in everyday life practicing, which is the challenge, because doctors, they could use it for one time, or for 1 month they used it, but then they are back to their way of practicing and regular way of practicing, and leading the change of practicing. That is the key point, to keep the teleconsultation going on the upcoming years. And every practitioner had to find their way of using teleconsultation, because it's different if you're a GP, if you're a specialist in a specific center, as in a rehab center, for example, or if you work in a hospital or a clinic or wherever. Each practitioner has to find their own way of doing it. But and also this the challenge and the understanding of working together, and the bridge between specialist and home, patient at home, is very important, and you have to practice it to to see the benefits of the teleconsultation.
Thank you. So, yes. So thank you to all of you for the different presentations we had on the different good practices in telemedicine. I suggest, as we do not have any more questions for the moment, maybe to make a small break of 5 minutes, if you want, before getting the presentation of Willy ALLEGRE on the REHAB-LAB. And thank you all for the different presentations. So we come back at 11:35, if that's okay for you, and we'll have Willy on the floor. Thank you. We are going to continue now, and thank you all for your previous presentations. We will pass a video on the REHAB-LAB before having the presentation of Willy ALLEGRE on the REHAB-LAB activity.
La 3D, c'est super. On peut faire ce qu'on veut, quoi. On est maître de notre objet. J'ai pu réaliser avec la 3D ce qu'on appelle donc un lave-lunette.
L'objectif du REHAB-LAB, c'est de permettre aux patients de réaliser par eux-mêmes leurs aides techniques en utilisant la technologie de l'impression 3D.
En février 2016, en fait, on a souhaité monter un FabLab intégré dans un centre de rééducation, donc au centre de Kerpape, au laboratoire d'électronique, dans un service un peu particulier, en fait, où on est les seuls en France à avoir des ingénieurs dédiés aux assistances technologiques pour les patients. On met à disposition une imprimante 3D, il y a un ergothérapeute qui permet d'accompagner n'importe quel patient, un référent technique.
Les ergothérapeutes vont avoir un rôle plutôt d'expert au niveau médical. On va apporter toute l'expertise au niveau des capacités motrices, intellectuelles, cognitives. Nous, on arrive avec notre cahier des charges, des capacités du patient, des besoins du patient. Lui, il arrive avec ses envies. Et on va aller voir l'ingénieur et on va réfléchir ensemble au projet qu'on peut mener. 6,5. On est parfait. Est-ce qu'on se base là-dessus? Là, on a pris la distance du bas à vos boutons du haut pour que ce soit celles les plus faciles. Le boîtier qu'on a créé ici avec Jérémy et Tunchai, c'est un boîtier qui comporte 3 contacteurs. Donc, il y en aura un pour avoir accès à son ordinateur, donc pour avoir accès à Facebook, sa boîte mail. Un contacteur qui pourra avoir accès à sa synthèse vocale, son iPad qui est sur son fauteuil, et un autre pour son contrôle d'environnement dans sa chambre.
Les techniques qu'on va faire à l'imprimante 3D va permettre de tenir mon poignet droit pour accrocher un stylet dessus pour pouvoir utiliser ma tablette au fauteuil.
On a 254 aides techniques qui ont été réalisées par des patients impliquant plus d'une centaine de patients. On a également 35 objets suffisamment polyvalents qui sont installés dans un site de téléchargement d'objets grand public, ce qui a fait l'objet de 2500 téléchargements. Et pour la petite histoire, on en est à 8 km de fil utilisés pour l'impression de ces objets. On a par exemple des supports de verre. Donc ça, c'est quelque chose qui est utilisé dans la vie courante par la personne qui a des difficultés de préhension du verre.
J'ai déjà fait une aide technique avec l'imprimante 3D en faisant un porte-gobelet pour faire le prolongement de la coudoir pour pouvoir boire toute seule.
On a également ce qu'on appelle des fourches qui se substituent à l'extrémité du joystick du fauteuil et qui vont permettre à une personne qui ne peut pas manipuler ce joystick de poser sa main dans cette fourche pour pouvoir piloter le joystick. C'est personnalisé en fonction de la morphologie de la personne et on peut avoir un support à plat ou éventuellement un support vertical de la main.
Le super avantage du REHAB-LAB, c'est qu'ils vont pouvoir participer activement à l'élaboration des techniques, faire qu'elles soient la plus proche possible de leurs attentes et de leurs besoins, de leurs goûts.
Donc au départ, on est parti de ça. Aujourd'hui, voilà le résultat après plusieurs séances de travail. Mais sauf qu'il y a une contrainte en plus, c'est qu'il devait être pliable. Ce qui n'y est pas sur le modèle.
À partir du moment où j'ai été acteur, où j'ai choisi la couleur de mon aide technique, je l'ai adaptée en termes de dimension, j'ai choisi les matériaux, etc. Alors, je me l'approprie davantage et je suis plus à même de l'utiliser par rapport à une aide technique qu'on m'aura donnée et qui est censée répondre à mes besoins.
Okay, so I'm happy to introduce now Willy ALLEGRE, who is engineer at the REHAB-LAB at Kerpape Center, and who is going to present the activity of the REHAB-LAB for creating assistive devices by using 3D printing. So Willy, we will pass your slides and the floor is yours.
Thank you, Céline. Thank you to Biotech Santé Bretagne a lot for this invitation. So yes, I'm going to give you feedbacks about the REHAB-LAB concept and behind it 3D printing and assistive devices, which is a concept mature enough to be scaled up today to various health and care organizations in Europe. So briefly, on the next slide, you can see Kerpape, which is one, let's say, of the biggest rehabilitation centers in France, relying on more than 50 years of experience on patients' care, so with motor disabilities and or brain damage. Mainly, there are more than 200 beds and more than 400 patients per day. And both children and adults spread in different units such as neurology, traumatology, pediatrics, care, cardiac re-education, respiratory also re-education, etc. So we work as a multidisciplinary care to address this issue. And maybe one, yes, on the previous slide, you can see that well, we have specific units such as the electronic lab integrated with engineers integrated in it. And sorry, for the next slide, you will see the main activities of this special unit, which is unique in France in the sense of we have engineers integrated in a rehab center, both involved in clinical activities for patient care, but also in research, development and innovation projects with both academic or industrial partners. And our third activity is about services. So we can work as experts on assistive technologies for companies and healthcare organizations related to assistive technologies. And so we will launch an innovation center, which will be called Co-work-It, integrated in Kerpape, but working closely with different let's say, Britain actors in the field of innovation and handicap to be able to spread on a national scale. So on the next slide, you will see the different field of expertise of our units. Of course, there are more than this actually on virtual reality, for example, on exoskeleton, also rehabilitation. But in our unit, we mainly work on IT accessibility, wheelchair adaptation, augmentative and alternative communication, and home automation, and Internet of Things, how to control the home. And one new area we developed a few years ago is digital fabrication to design technical aids, custom prostheses, etc. Very custom-made objects of daily living, which is not today enough tailored to user needs. So we need to create custom assistive devices with the help of digital fabrication. So on next slide, 5 years ago, we have seen that FabLab, for fabrication laboratories, space dedicated to digital fabrication, do-it-yourself, knowledge and tool sharing, which are still developing in a lot of different towns in France and all around the world, is something very, a concept very interesting for us. And we decided to take this concept and to adapt it to be able to fit health and care organization. So on next slide, you see the REHAB-LAB concept. Take, of course, as input the same points. So do it yourself is like handicap permanent or patient expert, for example. We work on a collaboration chain with the patient or the citizen, which is the leader of the creation, the design of its own assistive devices, and is helped with an occupational therapist or healthcare professional and a technical supervisor. And in this frame, we only work on assistive devices, small objects of daily living, with the use of 3D printing, and mainly low-cost 3D printer. So on next slide, you can see the collaboration chain of the REHAB-LAB, where the citizen patient has its own expertise of its situation and is helped with two kinds of professional. One is a healthcare professional. Well, let's say it's a role of healthcare professional with a medical expertise, user needs related to ergonomy, for example. And one other role, which can be take as by a healthcare professional also, is a technical supervisor able to watch and to help people to design, so to use the CAD software and also to use the 3D printer. So this collaboration chain is very innovative. Behind it, the innovation of REHAB-LAB is not the use of 3D printing, is more an organizational and a social innovation behind it, on the way patient could be involved in the design of its own assistive devices, and more generally in the rehabilitation process. So on next slide, you can see a lot of benefits we focused on related to 3D printing, which is a digital fabrication. So 3D printer, for those who are not familiar to, take as input a file of a 3D object, and then he has to print it slide by slide until having the entire physical object, as you can see on the small video here. And because it is a digital fabrication tool, 3D printing has a lot of benefits compared to traditional tools to do custom-made assistive devices, such as cloning, adaptation, design. For example, you can choose the color, the materials, the shape of your own object. You can master the weight of the assistive device, and of course, sharing is a great benefit of 3D printing because we talk about specific needs which involve specific assistive devices, but it is kind of custom fabrication, but spreading worldwide, because one object made in Kerpape Rehab Center here in France can be shared, and is shared actually, with some other healthcare organizations all around the world, and who fits exactly the same particular needs for one patient. And so I think this field is an emerging one, and we are proud to participate to it. But in the near future, we would like to develop the assistive devices database so we can reach the goal of integrating this type of activities in health and care organization. So most of all, accessibility, appropriation, and occupation, as you can see on the right side, are the most promising interests for 3D printing for us, as we'll see in the presentation. So on next slide, I'd just like to say that 1 year after our first experiments, we decided to communicate, of course, and we have a lot of feedbacks from healthcare professionals, mainly occupational therapists in France, who were asking us how I can put in place the same organization, a REHAB-LAB, in my own organization. So we decided to launch trainings, and then to pick general needs in this field in France. So I can summarize it right here, is to have a framework for organization to share knowledge and feedbacks, to have also a technical support and trainings, and to access a technical watch, tutorials, documents, to be able to integrate this type of activity in my own organization. And Kerpape, we decided to launch what we call a REHAB-LAB community, a network of REHAB-LAB, sharing the same organization, the same process, and also sharing our common activities. So we have now a charter written in English, sharing with different organizations in Europe, and where Kerpape is seen as a community manager, not the chief of the network, but one colleague and one organization who is responsible for the development of the community and the animation behind it. For example, we are developing right now a collaborative platform, will be a great tool to share knowledge, tools, etc. So on the next slide, you can see one photography. It was last month in France. There is a 16 REHAB-LAB right now. More are coming, and 4 REHAB-LAB in Europe. Yes, as you can see, more than 600 assistive devices, custom assistive devices, have been designed, involving more than 300 citizens or patients. So on next slide, I'd just like to do a quick feedback about 2 European projects. On the next slide, yes. We are involved in, but also we are leader of. It was a 2 call for project launched by Digital Health Europe, On the first one, we had the opportunity to transfer the REHAB-LAB concept to 3 adopters from Europe, in Italy, in Belgium, and in Denmark. And now, and I want to say also today, is the kickoff of the second project, the second Digital Health Europe project, to do quite the same, so to help 6 new organizations across Europe mount their own REHAB-LAB. If I can share a vision with you today, the goal is to have an international network of REHAB-LAB and share common professional practice and to tackle some issues I can talk with later if you want. On the next and last slide, you can see let's say 3 main areas of innovativeness perceived by the partners actually involved in the second European project. Some of the partners are really interested in the technological innovativeness, especially the use of 3D printing for designing custom-made assistive devices. Some of us are already familiar to this new tool and are more focused on social innovativeness about how I can involve citizen patient in the process. And then we have also 2 partners, let's say on a higher level of maturity, which are more focused on organizational innovativeness, on how to work in a network today, to be part of this network, to take from this network, but also to share and to give back to the community. So thank you for your attention. As I said, we are mature enough now to help other health and care organizations to mount a REHAB-LAB or 3D printing activities to improve care for patients and improve also or change the way we can place patients in our rehabilitation process. So don't hesitate to contact me if you have any question or if you are interested in participating to this new community. Thank you.
Thank you, Willy. Thank you. I know, well, you talked about your project, REHAB-LAB for All. I know that I would say, what's the next step for you, in fact, well, for especially in the field of training, because I know you have some issues at this level, if you're looking for.
Yes, during the 2 European projects, we have prepared training session, even remote training session. We are actually running right now. Let's say we are ready to help other health and care organizations to mount a REHAB-LAB and to propose training for this. So we are ready for this. And maybe we can work closely together with Biotech Santé Bretagne to find the best way to spread trainings across Europe so health and care organizations can be aware of this type of innovation and this type of support.
Okay, thank you. So we'll work on this together, and if any other partners are interested to work on this with us, they are welcome, of course. So thank you, Willy. Thanks a lot for your presentation.
Thank you.
We do not have questions for the moment. Just feel free to continue to ask them in the chat, and we'll check regularly. So I suggest now that, or before the next speaker, Sofiane Beruguet, we will show you a small video and on the VIGILANS and Sys-vision application, which is telemedicine surveillance of individuals discharged from hospital after a suicide attempt. And so we'll pass you the video, and then Sofiane Beruguet will make his presentation. Thank you.
Hi everybody, thank you for flashing my poster. I will present you in a few slides my presentation. I'm Sofiane Berruguet from Brest, which is a small medical hospital in Brittany, which is actually one of the provinces of France which has higher rates of suicide in France, but also in Europe. We have been working since 2015 on the systematic implementation of brief contact intervention for any patient which is discharged from emergency department in our province after a suicide attempt. We had some important insight from previous studies showing that keeping in touch with patient could be efficient in reducing suicide attempts, and we proposed a decision-making algorithm in order to try to reduce suicide attempts and improve efficiency of brief contact intervention. The main proposal is about having a system which is efficient and only based on informal contacts with green cards, phone contact, and mail contact. We have been deploying this system all over the province with a team of nurses which are actually performing the phone calls, at least 2 phone calls during 6 months after a suicide attempt. So now we have the issue that most of our patients are not reachable at 6 months, and we have been thinking about incorporating some of the existing e-health devices like smartphones, social media, and wearables in order to cluster risks in a suicide risk focus and improve decision making in these patients. Let's have a quick look at what are ecological data. Ecological data are data that can be recorded from electronic devices, and the core concept is that you can gather data from patient when he is in own environment in order to proceed them, in the case of e-health data, to proceed them using data mining techniques and propose early intervention or use them during consultation. We also know that there is a link between clinical data, for example depression, and digital footprints, which can be increased or decreased according to the clinical setting. I will not go through the details of this method, but we know that artificial intelligence method could help us to cluster the risk. For example, in this case, we had 2 groups of patients just looking at the electronic health record after a suicide attempt, and we have shown in a recent paper that we can easily show 3 clusters: cluster of women with alcohol and depression, which was a cluster with intermediate risk of suicide, a cluster of men with substance alcohol misuse, which was a high risk cluster, and a cluster with no gender and with work incapacity and low education level, which corresponds to a low risk cluster. We also proposed in several papers to use electronic devices in order to gather data directly from self-questionnaire performed by the patient himself, and also with some results on variables which may explain the number of suicide attempts after discharge. Another proposal is to incorporate some data provided by wearables, and in this case we have been conducting last month a study on monitoring the sleep, which we know that can be related to suicide risk, and also incorporate general raw data analysis in order to correlate it with patterns of risk in suicide attempters. So the general idea, which could be the the main idea of this poster is that we currently have several sources of electronic data in patients, and could use this data in order to improve the personalization of brief contact intervention and support a decision in a dynamic way for clinicians. Many thanks for your attention.
Okay, so everybody it was possible to see properly the video for all of you? Yes?
For me, that's fine. Thank you.
Okay, good. So I'm happy to welcome Sofiane Berruguet, who is going to make the presentation now, and he will be our last speaker. He's responsible for psychiatric emergencies at the Brest Hospital, and so Mr. Berruguet will present tailor-made surveillance of individuals discharged from hospital after a suicide attempt. So the floor is yours.
Thank you very much. Thank you for the invitation. And
yes. No, we'll just pass your slides. Sorry. We'll pass the slides for you.
Okay. Can I pass the slide? I do have the control on the slide.
We can. Okay, we can make it for you. Okay.
Oh, it's fine. It's fine. I have it. It's fine.
Okay.
So thank you so much for this opportunity to present this work. So this is a collaborative work between SME and the hospital and the University of Brest. So I presented I made a focus in the first presentation over what can be done on suicide, because you perhaps aware that suicide is a very tough problem in Brittany, but I think that this framework could be applied also to other clinical settings, and especially chronic diseases. So this is why we have been choosing suicide. Sorry, but I can't pass the slide now. Is there a way to pass them? I had the control for the first time, but not yet. Not anymore. Okay, thank you. So I have been thinking about talking about brief contact intervention, but we can think that there is almost the same framework and possible contact framework with other chronic diseases. In the suicide prevention setting, what we do use is teleconsultation or phone consultation. So it's a kind of low-tech way of contact, but this is also possible to have the reach with the patient with new devices. If I can pass the slide, it would be great.
We will do it for you. Don't worry, because we had problems. Yeah.
Okay. So you can go through the other slide, please. Thank you very much. So you can pass all through this. This slide was only to show you kind of animation of what we are doing. To think about the framework is to have in mind that you can have a very specific expertise in one center of a general province, for example, in suicide prevention, but as I said, it could be over any kind of clinical setting, and rely on this expertise using several electronic devices in order to get readily accessible this expertise in any center of your province, or you can work also all over the country. So in this case, we have been gathering a lot of clinical data. You can stay on the next slide. Thank you. We have been gathering a lot of, and we are thinking about implementing other clinical devices, other electronic devices, in order to proceed what we can call the digital footprints, which is a kind of mix of many data from many sources that you can record in a clinical setting and proceed them in order to make clinical decision. In other words, for example, to change the way you treat the patient or to settle an appointment or any kind of intervention. Can we pass to the other one, please? Thank you. So this was only to show you that this project was a tight collaboration between Sys-vision, which is a French company, company from Brittany, from French Brittany, and the Hospital of Brest. And we build a general framework, which is the SitWiz web. It's not really a website. At the end of the day, it's more of an electronic framework which is able to gather data, analyze them, and give a feedback to the clinician over any kind of disease. Can we go to the other one, please? So this is basically the interface is a kind of is a web app, but we also have a strong back end which is processing the data and able to, as I will show you on the next slide, to get feedback for the patient and the clinician in this way. So this is typically the clinical view, which is highly tailorable, and this is we have to have in mind also that this kind of intervention are implemented in an hospital setting. So the people who are using this app are nurses or doctors that are working in public hospitals. So one of the main challenging issue is that you have to handle with the existing information system, which are not always able to collaborate with this kind of features. So we choose to make it a kind of external of the existing information system in order not to have any issue of, for example, interoperability, which means that for now, at least in France, this kind of intervention has to be implemented in very specialized purposes. In this case, in Brittany, we use it on suicide prevention. Some of our colleagues in Spain are using it over cancer follow-up. So you can, for now, we are not able to make it as one piece of information system, and the objective of replacing the existing information system is a kind of difficult to reach. So we can go through the other one. Thank you. So as I said, we have two kinds of interfaces because the data can be proceeded from the clinical interviews from doctors, but also from the patients, and patients have private access to this kind of app and also can connect with the wearables, for example, personal wearables, only in a very specific research setting, because as you know, most wearables are customer-based wearables, so they are not medical devices, and it's quite tricky to handle with the security and data privacy purpose with commercial products. Next slide, please. Thank you. So the general framework is the following. We have a lot of sources, possible sources. So now we have to examine what are the sources that can be explored and in which clinical setting that they can be explored. The sources are only the base, a piece of the general framework. And so we are now working on the data collection process and the data mining process that will help us to because some of the clinical outcomes or the quality of life, but I think we should get in mind that the main purpose is not having these devices like a treatment, but that they can have a strong impact on health outcomes. Can we go through the following, please? So one of the methods that we can use, I spoke about that before in the video, is the way we modelize the impact on this kind of device. And this is a way to modelize it. Let's think about a patient that has been hospitalized for a while in the hospital. With that kind of framework, we can get many data from many patients and have a quick look on the overall sample of the patients you treat in this hospital, also when they are at home, when you get some data from the patient that is at home. We can go through the next one, please. So this is typically the kind of results that are not really digestible for most clinicians and nurses, but our aim is to help medical staffs to identify also in an outpatient setting the patient that have more need, and in this case there was the black patient, the black points representing the patient that needed more intervention and had the worst medical outcomes. Next, please. So as I said before, we have been thinking about other sources. The first one and the easier is the wearable. Next, please. So wearables are quite interesting because you can they are quite accepted in the general population, especially in population with mental health problem, because they can give patients a quick feedback over some of the health outcome, like for example sleep or activity. Next, please. And again, the other issue is that the current wearables are mostly commercial devices, so the medical interpretation is a kind of blurred by the marketing approach of the companies. And of course, we are still handling with we still have to handle with the privacy and the security of the data issues. Next, please. Another way to get data, and especially to get raw data from outpatient, is to consider that the digital footprint, which are all the data, all the numeric data produced by the patient, can be gathered and analyzed in a way to make some clinical interpretation about that. Next, please. So this is a work we perform with a partner in Spain, and the general idea was that we could be able to identify depression. You can go to the other one. Thank you. We can identify depression symptoms only by identifying some changes in the flow of the raw data from a smartphone. When I say raw data, is that we gathered all the data without any semantic tag, which means that we were not listening to the conversation or reading the emails or seeing what kind of pages were consulted by the patient. But we had a general idea of the flow of the data, and we tried to make in correspondence the flow of the data with the clinical symptoms which were explored and observed in the clinic. So next please. And this is the kind of results that we get. So we have in the upper draw figure and in the lower figure what was the algorithm able to identify? And this is not really interpretable as it stands, but we can see that there is a kind of correspondences between what the algorithm identified in terms of period and what the clinician identified also in terms of period. Of course, for now, we don't have any correspondence between the clinical significance between the depression and what is observed in the raw data of the smartphone. Next, please. Perhaps we can go through all of this data. So we already saw that. The general framework is the following, is how we can incorporate some data proceeding from the wearables and social media. Some people are working also over social media. Our team not yet, but there is a very high focus on social media due to the accessibility and the amount of the data that can be gathered by this way. Next, please. So this was the point of the social media. In the case of suicide prevention, for example, some colleagues have been thinking about having a kind of communication team and intervention team that would be able to identify risky messages and get in touch with patients or users that could need help. And you can see that this kind of framework is associated with a lot of ethical issue, because this could mean that someone can reach knock your door if you make a post with a suicide ideation inside. Next slide, please. So I will perhaps hand over this general framework. So the general idea is we can gather data from both hospital setting and outpatient setting, and above the telemedicine strategies, the classical telemedicine strategies, we could think about building a general framework that will help us to identify within a sample of risky patients which are the ones that need immediate intervention. Thank you so much for your attention.
Thank you, Dr. Berruguet, for this very interesting presentation. I don't think we have questions for the moment, but I would have one, maybe more on the aspect of, I would say, what's the next step for your project, and in terms of transferability of this experience at EU level, or what could you tell us?
Thank you for the question. So the next step is to try to get some other insight from other clinical settings, and for this we have some collaboration with colleagues from cancer prevention team and rheumatology, and also pediatrics. But I think in the field of which is the main focus of the project, in the field of suicide prevention and mental health, we are currently building a consortium in order to apply for a European grant in order to put together the expertise of several centers. And we already have in the consortium people from Spain, Germany, and France. So I think the next step is to go over a huger assessment of what this method can bring into the framework of suicide prevention, but also in the management of chronic diseases in general.
Okay, thank you. So we'll keep an eye on your project and see what are the next developments. So thank you very much for all of you for all the different very interesting presentations on our good practices in Brittany. If you have any questions, just do it in the next, well, in the few next moments. So that was a very rich morning with all these different good practices. And of course, we will send you the different PowerPoint presentations to the different participants. And if you have any questions coming afterwards, we will transmit it to our different speakers. We will also continue, of course, our common work on the evaluation process of these good practices. And that is the same for our partners, and let you know about some other European practices that might be quite similar and which might enrich each other from their experience. So this afternoon we will continue this intensive day with our thematic workshop. So for those of you who are available, I invite you to continue the day with us on health, innovation, and ecosystems. And so we'll have about, we'll come back at 2 p.m. for this workshop. And before letting you go, I just have a personal message to pass to the different partners of the intensive project from my former colleague, Céline Quéron, who was previously involved in the project at Biotech Santé Bretagne, who is just passing a hello to everybody and is happy to see that the project is continuing to develop and enrich each other with each best practice. So thank you all for the different presentations, and we get back to you for thematic workshop at 2 p.m. Thank you. Hello, everybody. I hope we are very happy to welcome you again for this afternoon for our thematic workshop, continuing our intensive project today. So this afternoon we will talk about e-health in innovation ecosystems, and we will have 3 different presentations. The first one with Gregor Cusack from e-Alliance. On the screen, who will be happy to present e-Alliance network and its activity and the connection we can make with our projects. Then we'll have a presentation of Anne-Claude LEFEVRE, our director at Biotech Santé Bretagne, here on the left. And we also can see Renaud LEFEVRE, who is our stakeholder at the GCS e-Santé. And afterwards, we'll have a presentation of the Finland Ecosystem in Innovation, Sami Perala, who is from the Senajoki University. So now I'm going to let the floor to Gregor, who will present us the e-Alliance network and its activity. Gregor, the floor is yours.
Yes. Okay, thank you very much. So my name is Gregor Cusack, that's how I pronounce it. And I come from Slovenia. For those who watched Tour de France in this year, 2 of the winners of Tour de France for the first time in history, Tadej Pogačar and Primož Roglič, both come from my country, okay? So it's not that I cycle, but I like to take pride, you know, in certain things that don't belong to me directly. Anyway, jokes aside, I'm really happy for being invited to today's event. I hope you had a nice first part of the day. And what really makes us happy and why we basically do what we do at ECH Alliance is to see that different people are connecting. So when this is an international connection, this is very close to us because your local connections, so the way you cooperate in your local ecosystem is much more up to you. So it's our role where we can be of benefit is we can give you in different cases, in different projects that you're working on, we can help you reach international connections. And of course, you can do the international connections on your own. You don't need us for that. But we were successful, I would say, in the last 8 years since we were established, and we managed to connect quite a lot of people. But what I'm most proud of if when we see concrete cases, because it's very easy to talk about, you know, doing the connections, connecting the dots, as we say, but it's much harder to see, you know, where it really helps the patients. So I think what is super important is to see that our activities in the end help somebody. And when you realize it and when you know that is true, then this equation that we are in pays off, in spite of a lot of work, in spite of the complexity, in spite of the very strenuous time schedules sometimes, even crazy Zoom sessions going all over the place. I don't know what's with you, GoToMeeting, WebEx, Teams, and all other kinds of video connections. I hope you can also sometimes just switch off the computer and the mobile phone. I think that's very important for health, also for mental health. I usually speak really fast. If I'm too fast, just raise a hand, complain to Adeline. I don't take any offense, and I like to sort of be understood. So for me, it's more important to be understood than that I'm liked or that you think that I'm fancy or something like that. For me, it's much more important to understand also your needs. So please come forward with comments or questions that I think you can put in the chat. So this is the way this is supposed to be done today. So I have a deck of slides here, and I will go through it, but please understand that the work that we do is does not need slides. There are many things that we are doing, and I will just use this so that you will follow in a little bit easier fashion. But anyhow, I think all of this that I'm going to talk about is connected with what I said in the start. It's good to see people connecting, projects connecting, and all for the benefit of the patients and the citizens. So my name is Gregor Cuzak, as I said. Feel free to connect with me. So we are now, you don't have to be shy. We also have French-speaking people in our team. I only know a short poem in French, which I will tell now and embarrass myself completely, okay? I did not announce this to Adeline, but it's very short. And it was told to me when I was a very young kid, you know, so it might be wrong. So here it is. So, j'aime des choses, toi et la rose pour un jour, toi pour toujours, something like that, okay? Did you understand, Adeline? Okay, good. Okay, I know it's a nice poem. I know what it means, actually. So, who are we? So we are the European Connected Health Alliance. We are absolutely not the only such network that exists. If you will go and search, I think you will find comparing networks like Eurega, you will find EIP on AHA, you will find Echtel, you will find some others. However, what we have is we managed to gain scale. So we managed to really put a lot of people in our network. And one thing that is really important is that we are not depending on a project. So we are not here today and then gone after the funding is gone. But also our ecosystems are not there just to be there for a project. So our cooperation, when we started with Bretagne, I think it was 2 years ago, if I'm not wrong, it is not meant to finish. Why? Simply for the fact that we need activities that are sustainable, because the patients are here all the time. And also the companies and doctors and hospitals are not here like usually we see in European projects, when there is one project and then it's sort of over, but it stays. So what do? So we are a member organization. We have these top figures that you see here. we have more than 800 organizations that actually applied for membership. So this is a special status with us. You have to apply, and it means that you can either pay if you're commercial or be granted free access if you're in another status. And some of our members also pay us fees that are higher than our, let's say, regular fee for depending on the size of the company, because they want to use us for their communication. They want to be helped by us to do the networking for them and similar things. So this is membership. Then the second thing is this 16,500 experts. It's basically the approximate size of the newsletter that we are sending out. So this is not people who are closely affiliated to us, but it still is, I think, a very good mailing list. And this mailing list we use at least once every month. So each and every month, we ask our ecosystem, including Bretagne, we ask everybody to, if they have some news that they would like to enter into the newsletter, they can do so. And we promise that our ecosystems, like yours, can basically use this newsletter to basically talk about yourself. For one article, we can ensure this. We're a not-for-profit organization. We were started in Belfast in Northern Ireland, and the reason for that is that Brian O'Connor, who is our chair, was born there, if I'm not wrong, and this is how we started. But since the Brexit, our organization also formed a headquarter in Dublin. So we still have in Ireland, we still have a European seat, and we can participate in different European projects. In reality, how we operate, we have people all over Europe. So I sit in Slovenia. We have 4 or 5 team members in Barcelona. We have somebody in Portugal. We have somebody in Wales. We have somebody close to Manchester. We have a few people in Belfast, a few people in Dublin. We have a Polish colleague, Karolina, who works in Finland already for about 10 years, and some other people. But altogether, if I would just put the number of people together who are supporting you here, is about 20, maybe 25 people. So it's fairly small team, I would say, but the reach is very, very high. Now, how do we do that? Basically, we network. So we don't do everything on our own, and also the services that we provide are more often very, let's call them superficial. Now, somebody would say that is very bad, that it's superficial. I say it's not bad, because we have a very wide reach, and with this very wide reach, we also understand that you need really top experts. So when you will need somebody for, let's say, artificial intelligence, or somebody dealing with genetics, or somebody dealing with value-based healthcare, we will be able to identify fairly quickly who are the top experts around Europe. Again, you can do this on your own, but consider us your special helper, or somebody who can provide help to you. We basically, the way we work with Bretagne and with other ecosystems, I will show you later on who they are, is we are cooperating on a voluntary basis. So it's not that Bretagne pays us a fee to work with us, neither do we pay Bretagne. So we work for free, each other. So again, why do we do that? Simply because we believe that doing things together is better than going alone. We believe that our role is helpful, and we do find revenue in projects, European projects, where we also participate. So sometimes we can put you in such consortia, or you can put us. That also happens. Ecosystems invite us to be dissemination partner, for example, quite often. or we get members and we get sponsorships, we organize events, and those are the opportunities where we earn money. There is also a special type of let's call it revenue, but we don't consider things directly from the revenue perspective, which is we are very active in European presidencies. So currently it's the German presidency. We do consult the German government on this presidency in terms of digital health. And we had so far, I think, 8 presidencies. It started many years ago in Greece. There was a very, very strong initiative about, I think, 2 years ago in Estonia, where we started the Digital Health Society. And we are also bound to have participation or consulting for the Portuguese and also for the Slovenians that will come afterwards and so on. So this shows you that we can connect either small companies, startups, even individual professors, and on the other hand, governments or ministries or hospital networks, also other networks. We are open, and this is very important for us that we bring all these different stakeholders together. So I think it would be good to proceed with the slides, because a lot of what I'm talking about is on these slides. This is what I described already before. Now, also what you see here is that we expanded globally. Simply, when you create a network in Europe, which is our, let's say, home territory, you realize that of course the connections go everywhere. So one such case is Australian ecosystem that launched in this year. Australia has really strong connections with the university in Barcelona. So they've been on our events already for some time, but the European events. And then they said, look, guys, could we also do basically an ecosystem in Australia that would be a part of the ECH Alliance? Again, this voluntary connection. And we said, yes, of course. Similarly, we had ecosystems already earlier in Sri Lanka. We have very strong connections. Well, very strong. Brian used to work in China, so there is a strong connection to China. But in this year, especially due to Corona, because most events or all events are now online, this increased our introduction of new ecosystems really, really strongly. If I just tell you that a year ago we had less than 30 ecosystems, I think it was 28 at the end of the year, and now we are at more than 50 ecosystems. This, I think, tells you a lot. Now, I've been talking about this, and I will let me go forward and come to these points. If you have some questions, as said, please feel free to send them over. Now, of course, you have many different things that you can do if you are networking. It's a lot to deal with communication. I like to talk when I talk to my peers, like Adeline. Adeline is my direct contact in your ecosystem. And we are always open to have more contacts, but it's nice to always come to the same person. You get to know that person, understand what they're most interested in, where they can contribute, how you can help them, etc. When I talk to my coordinators, I'm coordinating different coordinators. That's my role. So I speak to people like you, to people like Adeline, every day practically. So it's either people from Finland, Greece, France, Portugal, and other places. And what I say is that we can deliver 3 types of services. On one hand, it's communication, so newsletters, and you tell us, what's going on, etc. The other thing is conferences, events. It's a type of communication, and then it's projects. Projects are, you get funding. They are changing things in your ecosystem. They are changing your ecosystem for the better. You are introducing innovation, because we are here to help you introduce innovation, both in digital health, but also in other areas like biotechnology, other areas of life sciences, social care, etc. So this is, I like to simplify things, and for me, in the end, the question is what we can do together to make the life of our patients and also citizens better and more worthwhile. Now, in terms of our members, I will not stop at these slides. I will just go through is just to give you a taste of different types of members that we have. So we will find organizations from basically all over the world. Of course, the majority still is European, but we like to understand, what their contribution is, how they improve lives of patients. But we also believe that partnerships are the way for the future. So it's not that big companies like here, Sanofi or Roche, that they have to innovate on their own. Of course they do, but it is in today's world when it's really easy to communicate, really easy to present from Ljubljana. That's my hometown, to you who are in Bretagne. I think you're in Rennes, right? If I'm not wrong. But we can do it anywhere in the world. So it also means that it's very, very easy to find potential partners anywhere in the world. So so different types of organizations that you will find with us. And this is one important part of the story that you will see. So this is a slide that tells you that we are very much, I would say, balanced in a way. So you do see that there is a lot of academia among our members, but still, it's not the majority. There is a lot of healthcare professionals, so healthcare providers. There is a little bit less industry, a lot of agencies. Patient networks are important, but also you see these networks, different clusters. So we do also partner with other networks. We believe that this is very very important. And now this is paying members. So this is where we find some revenue for us, for the team. But I already commented this a little bit earlier before. So this is quite a detailed overview of where we are in different localities. And now we come to the ecosystems. Now, so this is my work mostly. For me, I would say that perhaps this slide or this chart here on the left shows you very nicely about our commitment to not just talk about, let's say, startups and how they will create an innovation that will disrupt the industry, replace doctors, change the way hospitals work, etc. No, that's not what we do. It's a part of our job. So we do help startups, but we believe that it has to be a multi-stakeholder dialogue. So multi-stakeholder dialogue means that you are open to communication in your events to everybody, so that you don't enclose yourself into just doctors talking to doctors, and then policymakers talking to policymakers, and then investors basically talking to investors. I think that's boring. I think that doesn't provide as much value as the multi-stakeholder dialogue, although specialized conferences, of course, have a merit. They are needed, and this is normal. But we see that what we have to do is to get people from different areas to talk together. Now, of course, conferences do that. You go to HIMSS, you go to eHealth Week, you go to different, I don't know, projects, etc., and you will have this opportunity. As I said, we are absolutely not the only one, but this is our principle. Our principle is to always, make sure that we involve everybody. One of the consequences of this is very simple. We recommend that our ecosystems make events as often as possible free of charge. We don't see ecosystems as organizations that will earn a lot of money because they create events. I think where you can do business or find money is in your domain. So if you create computer software, fine, you will sell this software for the hospitals, But what is important is that you have an opportunity to speak to doctors, to the patients, to the policymakers, etc. So that's how we believe things have to be done. So you have to also admit those stakeholders that cannot afford to pay €1,000 entry ticket, which is sometimes happens with some conferences. So the way we approach it is, for us, the dialogue is more important in the ecosystems than making sure that those are businesses that can grow. Of course, it also means that you have to find different ways of how your ecosystem works, and we don't prescribe to you how you have to work. We are really happy to work with Biotech in Bretagne. And we understand, that your focus is, let's say, a little bit more in biotechnology, that you're very interested in the European projects, etc. We have different types of ecosystems. Let me show you examples. So this is something, some of the things that I've been talking about. So this was this accessible to all, no fee, multi-stakeholder I mentioned. Our ecosystems are always local ecosystems. So when people ask me about what is more important, is it ECH Alliance or the local ecosystem, I will always put the local ecosystem first. Why? You are closer to the patient. So it's very important in your ecosystem that you find good cooperation between even competitors in some areas. Try to bring all together. I like to say that in healthcare, there is no competition because everybody helps the patient, okay? Of course, we can discuss what it means. I also mentioned this permanency. You have to make sure that you are coming back, that it's not a one-time project. Sometimes some of our ecosystems have mandates, like a budget period for 3 years. And this agency then takes care of the system until 2023. What happens then? Sometimes it's a transition. Sometimes, the budget is gone. So it's really good to find a way how to stay active and permanent, and find reliable and sustainable sources of income. It can be membership, it can be government funding, it can be hospital funding. Different types of things. Now, leading with the need means try to be in the market, try to be close to your healthcare professionals and patients, try to understand what is important for them. It's not that your patients crave for perhaps usage latest gadget that was just brought out by, I don't know, Apple or some fancy company. Perhaps for them, the biggest urge or need at a certain point of time is, I don't know, more elderly homes. I know, building elderly homes is very expensive, but it's important that you understand. I'm not saying that has to be done. You really know it better, but do have a touch. You have to have this feeling, of where your ecosystem is at a certain point of time. And as said, put the patients in the center. Now, this is our network of ecosystems. You will see Bretagne also as part of the ecosystem. My personal role in Slovenia, which is here on the right, is that I started running my own ecosystem first here. It's not my own, it's several partners together. And I'm a co-lead of this Slovenian ecosystem together with Technology Park in Ljubljana. This is our example. Technology Park is also in Estonia. So they are a technology park. I'm sure there are some others, but the HealthTech Serbia, this is also, they are called REHAB-LAB. This is in Serbia. We have governmental bodies, for example, here in Scotland, also Highlands and Islands. Governmental involvement is also in Malta. We have governmental here in Belgium, in France. Then we have regional innovation offices or hubs that are a combination of industry and government and some grants, like in Spain, that's very regular or often in Spain, and other cases, of course. Now, there are some things that, of course, will now start overlapping a little bit. So I will not stop on every slide. This is a little bit of what I mentioned. So if we started as a European Connected Health Alliance, we are not changing our name, but we do see that there is also a global role that we can have, and there are some organizations that we started partnering with that are networking organizations in which we can establish cooperation and also help them with the services that we provide. Now, there's an interesting case I can tell you about. This is a first-hand experience case. So, Cluster Saudé de Galicia in Spain, that was in last year, so 2019, hired us, and in particular, it was my job to do this for their delegation of in one case it was 5 people or 6, in the other was more than 12. To organize a trip, so like a learning expedition, to learn about different ecosystems. So we organized a trip in which they saw different hospitals, homes for the elderly, innovation centers, even participated in conferences. And this was the case of, this is my ecosystem. It's called healthday.si. This is the Health Tech Lab in Serbia. This was one visit. This was in June last year. And then we went to the Netherlands in October last year, so 1 year ago, approximately. And there we visited at least, it was like four different regions. Altogether, when I was writing the report, I saw that we put together like about 36 different partners that presented to our colleagues from Galicia. And of course, there is always an opportunity to create some projects, to enter into some activities together, etc. And it's, of course, you can learn a lot. Then we do a lot of European projects work. Gatekeeper, I think this is a fresh one. There is a webinar that we will have on the 3rd of December. Presenting about Gatekeeper. I think there is there are open budgets available in the total budget is, well, it's not super large, but I think still interesting, 600,000 euro that will be available now in very short time. I also saw this as a new project, Gravitate Health. It's a very large consortium in which we participate, and some of these projects, I guess you know. But what is important is that in terms of how we are organized, we do have a projects team. So this team is capable of writing or participating in writing projects, in submitting the bids, and then of course, if we are successful, winning those bids and then producing work for this. So these are the different services. I've been talking about this a little bit before, and I think I'm already way past my time, because I was not checking, how long I've been talking. I do talk a lot. That's true. Adeline, should I stop?
Just maybe a few more minutes, and
yeah, we are basically very close to finishing. So it's just the Digital Health Observatory is one of our media project. It's a website committed to in-depth articles on healthcare. And then I mentioned this Digital Health Society. We had this, I think, a week ago. No, it was 2 weeks ago, and we had about 600 people participating. So it is, you could call it basically some kind of a think tank, or also, activity dedicated to really introducing this large scale changes to our healthcare systems, and it's very helpful also for these different European presidencies where we often consult. So this was a really quick overview. Sorry for going over time.
Thank you, Gregor. That was really interesting to have your presentation on all the different kind of activity you can put to our service and to the different ecosystems. I don't know, I think, well, for the moment we don't have any questions, but we'll continue to take them all along the afternoon and maybe come back later to. I just have maybe a small question. You said that you were in close link with the present EU presidency, the German one. Do you have any, I would say, any scoop on e-health issues for the moment about their work on this?
Yes,
and
the key initiative of the German government, I honestly don't know whether we had our hands in it or not, so I really can't claim that. But this common European health space, just check on Google, the European Health Space Initiative is the initiative of the German government in terms of, how to deal with the data. That data management is one of the key areas for the development of our ecosystems, because whatever you try to do in terms of healthcare, it comes back to understanding the data about the patient and also about public health, about the operation of different stakeholders. So Health Data Space Initiative is a German initiative of this current presidency. Several governments are co-signers of that. I don't know whether the French government co-signed this, whether they are together with the Germans on that. But since I think there is a strategic, usually partnership between France and Germany, I would say yes, but I don't know, honestly.
Okay. Thank you. Okay, so we will continue and we'll come back and see the connections with the Sys activity after. So now I'm going to give the floor to Anne-Claude Lefebvre, Director at Biotech Santé Bretagne, who is going to present the Brittany ecosystem in the innovation field and on e-health issues. So Anne-Claude, the floor is yours.
Thank you, Adeline. So my talk will focus on the Brittany e-health ecosystem in the field of innovation. So first of all, the identity of Brittany. So we are located in the western part of France, and we are an attractive region with an increasing number of inhabitants. So for example, in 2019, there were 3.33 million inhabitants. But a demographic aging situation with a higher number of people aged 75 and more than elsewhere in France. Our gross domestic product is worth 87 billion euros. The health sector is a strategic sector in Brittany with two main cities, in Rennes in the eastern part and Brest in the western part of the region. And we have a strong ICT sector and a high level of fundamental and applied research in life science. So the first part of my presentation will focus on the social and healthcare situation. So as for demographic features, the demographic aging trend is diverse in the 4 departments which make the region, so Finistère, Morbihan, Ille-et-Vilaine, and Côte d'Armor. So the figure on the right shows that the more aging places are in the center of Bretagne and also all along the coasts, where many people come back in Bretagne when they retire. And as for the health context, Bretagne has a favorable position as for community-based primary care. That is the number of general practitioners. It's around the same as in France. But it is less favorable as for the number of independent specialist practitioners, as it's shown on the figure on the left. If you can see, there are, for example, the number of surgeons or of psychiatrists is lower than in France for 100,000 inhabitants. Continuing the main features, there are 2 university hospitals in Rennes and Brest and 201 care institutions and 1,500 medico-social establishments and services, taking care of elderly and disabled people. And the main stakeholders as for social and health policy are ARS Bretagne, represented the Ministry of Health in Bretagne, the region, we heard them this morning, the 4 departments who focus more on social policies, and to a lesser extent, the cities can also be involved also in health topics. And the figure on the left compares the prevalence of diseases in Bretagne to the one in France. And for example, there is a lower prevalence for diabetes or chronic coronary diseases. It's about the same position as for cancer or respiratory diseases. And we have a higher prevalence for psychiatric diseases, as we saw this morning, for example, suicides. And the figure on the right details the health expenditures, and the amount is increasing. And for example, it was 10.1 billion euros in 2018 in Bretagne. And the recent law, it was in 2016, it promoted new ways of collaborations between healthcare institutions at a specific territorial scale. And the aim was to increase the shared medical projects in between these territory, in between the territory, and also to increase, to optimize the costs between them. And so, as you can see on the figure, there are 8 regional hospital groups in Bretagne. So my second part of the presentation will be the presentation of the health sector as for innovation. And so the ambition we have in Bretagne is the following: being a leader region in Europe, innovative towards a more preventive, predictive, personalized and participative medicine. So as a first overview, Brittany is a territory for innovations and experimentations on healthcare applications. And we are ranked second as for the R&D on digital technologies at the national level. And we are ranked 4th as for the dynamism on e-health at the national level too. As we saw this morning, since 2013, there is a strong affirmation of the health sector at the regional level, so in the regional strategies. We talked this morning about the smart specialization strategy, but also in the strategy for research and strategies for economic development. We are a region open to Europe, so we are involved in this intensive project. We are also member of ECHE Alliance, and we are also member of the European S3 technology platform on industrial modernization, and we are member on the one on medical technologies and representing the region in this network. And the sector is organized with 4 central pillars to address these medicine of the future challenges and to answer the user requirements. And the idea is to make stakeholders from innovation, economic development, the one from research and training, the one from social and care, and the one from society and territories work all together. So as many other regions, we address societal challenges, and we exploit deep tech innovations and specificities, and especially the specificities we have in the region. And we also try to develop new approaches, such as enhancement, interdisciplinary enhancement, not only technological and new usage innovation, but also new healthcare organizations, living lab approaches, and new businesses models. So the health sector in Bretagne is composed of 4 main domains: the medical technology sector, the e-health sector, the health biotech and pharmaceutical sector, and prevention and nutrition sector. So today I will focus on the medical technology and e-health sector. Just a brief presentation of Biotech Santé Bretagne, which is a non-for-profit technology innovation center, so devoted to healthcare innovation, and it's funded by public authorities and our membership fees. We lead the regional health sector and the innovation strategic area, which is called Health and Wellbeing for a Better Quality of Life. And we also support innovation projects from the concept through to the end product approved for the health market. And we follow and support more than 100 projects per year. We are a member of different national and European networks. We talked already about some of them, but also at the French level, France Biotech, the Forum LLSA, which is the National Forum of Living Lab for Health and Autonomy. And we work also in partnership with other regional innovation clusters in Bretagne, for example, on ICT with Imagerie Réseau, Photonics Bretagne on photonics, and on cybersecurity with Pôle d'Excellence Cybersécurité. So a brief summary of the strengths we have in Brittany. So we have 55 academia research teams operating in health, and we have the National Public Health School, which is called EHESP. And the research teams are involved in 18 big project investment for the future national projects. And we also have living labs and technological platforms. As for clinical research, we talked already about the university hospitals and the care institutions, but we also have a regional cancer center. We have 3 clinical research centers supported by the Ministry of Health, French Blood Services. We can also focus on the dynamic healthcare organizations. And for example, there is one in neurology, which is called Creben. And we also have skills in simulating for training, which is called CESIM. As for businesses, we have more than 500 companies in Brittany, among which more than 260 innovative companies. And it's quite increasing a lot because it's twice as many as 20 years ago. And there is numerous new companies creating regularly. And for example, also as for fundraising of those health companies, for last year, it was up to 48 million euros. And 51% of the companies are in the medtech and e-health sector. If you go into more details for the medtech and e-health sector, so as for medical technology for diagnosis and therapeutics, it's really a forward-looking and innovation-driven sector devoted to the medicine of tomorrow. And we have a specific expertise on diagnostic and interventional medical imaging, medical devices, computer-assisted medicine and surgery. So with over 80 companies, cutting-edge academic research, for example, on computer-assisted medical interventions or on communication and information sciences. We have a clinical institute on neurosciences. We have a Center for Clinical Investigation and Technological Innovation, which is specifically in cardiology. And we have core facilities in medical imaging. And also we have living labs for co-creating and exploring new ideas. And there's 3 which are labeled at the national level, and 2 in rehabilitation sector and 1 in assisted living sector. As for e-health, we have a long and proven track record, which has led to a dense network of digital companies which develop e-health technologies, for example, in telemedicine, in connected health devices, big data, artificial intelligence, cybersecurity, assisted living. So with more than 60 companies, we have a national technology research institute, which is called BICOM, and which is specialized in digital technology, including connected health and augmented healthcare. We have a specific expertise in health data analysis with, for example, at the hospital of Rennes, a platform which is called EOP for Hospital Clinical Data Warehouse. And there is the organization of a service to get access and to treat the data, and it's open to public and private research. We also have expertise in cybersecurity with the Pôle d'Excellence Cyber, and we also have strong skills in interoperability, for example, with the Integrating Healthcare Enterprise, which organize the annual Connectathon. And I will give you more information later about the EAT initiative. As for economic sector and some illustration of companies that develop innovations in medtech and e-health, you have here some keywords and the names of different companies that illustrate the health sector as for medtech and e-health. So the innovation strategy is supported at the regional and national level. So as for the national level, there are different initiatives with high impact for us. For example, the strategy for research, which is called France Europe 2020. There is a strategy for economic development, and for example, for it, the current concerns are on bioproductions or also artificial intelligence and medical device. And there is also the healthcare strategy, which is called Ma Santé 2022 to 2022, which has a roadmap for the digitalization of the healthcare sector. And there is a representation on the right with the house. And for example, the underground of the house represents the framework which will be managed by the national authorities. So with the ethic, security, interoperability concerns, and also strong services which are developed, for example, e-prescription, securing messaging. And at the upper part, all the co-building and cooperations with companies and users. And for example, there are 3 platforms, a platform providing services for citizens, another platforms providing services for the health professionals, and also the Health Data Hub, which is the platform for exploitation of public health data. The idea is to have a one-stop shop for public and private research. And I told you just previously of EOP, which has been developed in the western part of France and in Rennes. And so EOP will be one of the nodes of this National Health Data Hub. At the regional level, so there are 2 main points. We have a strategic committee to boost the economic health sector. And as for the next S3 strategy, we already talked about it. There will be a strategic domain innovation area on health. And the objective of this strategy is, there are 3 strategic objectives. The first one is to boost the international leadership in medical technologies, also to develop innovations in biotherapies, and finally to reinforce the regional excellence in prevention as for the links with environment, nutritional health, physical activities, and so on, and also well-being in the context of global transitions. And you have on the right side in red the 6 leverage actions on which we will focus during the next period. And finally, I wanted to say some words about some innovative projects. So a first example is a world first achievement that has been done by the Technical Research Institute BICOM and the Rennes University Hospital. So it was in 2019, and a team from the Rennes University Hospital carried out the first ever series of surgeries using a solution that had been developed by BICOM. And the idea was that it retransmits images of the equipment used in the operating room, perfectly synchronized and in real time. Really, it's a new standard for real-time streaming video management, and it brings a major advance for this upcoming developments in surgery. My second example is related to health data science and the link with the EOP platform. And for example, what can be done with a company. So the example is with a company which is a biotech company called VitaDX. And VitaDX develops a new head tool to early diagnose bladder cancer. So it's based on fluorescence and machine learning. And the company used this EOP platform and the access to these clinical and biomedical data to improve its machine learning algorithm and to be able to offer an efficient solutions for practitioners. Now, other examples of projects, more innovative projects addressing health pathway and monitoring of patients. And first example is the Folony project, which has started a few years ago. And it's a huge project with 10 partners, among which research teams, but also companies and the hospitals of Brest. And the objective of this project is to propose a totally innovative workflow in knee replacement surgery as an answer to the changes in the demographic population for the next 20 years. The idea is that more and more people who need knee replacement surgery are young and they want to remain active and still practice sports and so on. So it's really a main concern. And the project aims at defining a set of technological solutions to decrease the number of revisions. So a personalized implant design adapted to each patient anatomy. So it's done with 3D printing. The use of augmented reality in the operating room to optimize the surgical techniques. And finally, the integration of new generation of sensors in the implant to improve post-operative follow-up. So that means that the patient will come back home earlier, and there will be data from the sensors in the implant that will be sent to the practitioners to see if everything is okay for the patient. Second example is with the MedTech SME called Biotech, and it's about remote monitoring and prevention for patients with chronic respiratory diseases. And so the company has developed and markets a connected medical device, which is called Boraband, and it's designed to improve the care pathway for patients with respiratory insufficiency. And so it's this company got specific funding this year from Big Pharma through a call for project called Coalition Innovation Santé. And it was really important during the COVID crisis because it was important to be able to follow up patients with respiratory diseases. And the third example is with an e-health company called MAPUI Labs, which develops two kinds of platforms. The first one is called MAPUI platform, and it's a web platform for pharmacists in hospitals to boost collaborative inter-hospitals medicine management system, and so manage collaboration around drug tension or also medical device tension. And the idea is to collaborate and help each other according to the number of drugs and medical devices they have in their own hospitals. So they also got strong support this year from the Ministry of Health during this crisis. And so they also developed a second platform, the Hospiville platform, which improves drug management patient tracking system between pharmacy, so outside the hospital, and hospitals. And the idea is to reduce drug iatrogenism and also to connect pharmacists and hospitals, and also to improve patients' understanding of their medical treatments. And to finish with, I will give some words about the HIT project, which is a project selected after a national call for project, which is Territoire d'Innovation. That means innovative territories. So that means a project led by a territory. And so this project has been selected, and it's financially supported by national and regional funds, and it's called HIT, and it deals with integrated care in practice for disabled people. There are 3 founder partners for this project, and partners which initiated and still manage the project. The first one is Lorient Agglomération, which is the city that is in this territory and which is very active. The Kerpape Rehabilitation Center that we heard this morning, and also Biotech Santé Bretagne, our association. And so the objective of this project, there are strategic objectives, which are to develop an inclusive territory for all citizens with disabilities, to develop empowerment of the patients and also patient experts, and also finally to develop new solutions linked to digital technologies, to their uses, and to new organizational and business models. And there are also operational objectives, which are to unit territory stakeholders to create a competence center for co-design, which is called the Co-work Kit. This morning, Willy talked about it, to test into real life spaces the innovative solutions that have been developed, to include disability challenges into training, to assess the social and medico-economic impact, to modelize and disseminate throughout France and beyond. So it's a huge project with 60 partners, which are, for some of them, healthcare facilities and medical social institutions, companies and support, local authorities and institutions, user representatives, research and training, and technological innovation centers. Why this area? It's because Lorient-Aglo, which is the main city of this area, lays foundations of an inclusive territory since the 1970s, and also because there is the biggest rehabilitation center in France, which is located there and which is very active, which is called Kerpape, that we heard this morning. There are also other reasons, as for technological innovation initiatives and social innovation initiatives. So the project is divided into 7 main actions, and it will last 8 years. It starts this year and it will finish in 2026. I will go through the different actions very rapidly, very quickly. The first action is the framework. It's the definition of the different health pathway and life pathways for these disabled people, and also all the evaluation, which is social, medical, but also economic evaluation of the different solutions that will be created. The second action is the creation of this competence center for co-design, which is called Co-work Kit. Then the actions 3, 4, and 5 are the development and the experimentation of innovative solutions in care during all the pathway. So in care facilities, then at home, and finally in the city. And the 6th action is about training, and the 7th is about outreach dissemination. So concretely, there are 61 innovative micro projects within this project. And just some example, some projects are about the prevention of pressure ulcers, and others are about re-education, innovative tools with augmented reality or with serious games. Other micro projects are on telemedicine. Others are about increased accessibility to sport activities for these disabled people, or also home automation and assisted living. I will finish with this last example, and I thank you very much for your attention, and don't hesitate to have a look at our website. So for the website of Biotech Santé Bretagne, but also the website of the health sector in Bretagne. Thank you very much.
Thank you, Claude. Well, to complete your presentation, 2 of the projects that you mentioned, Biosensei and MAPI platform, are parts of the best practices we identified within the intensive project. So we will continue the evaluation. And also, well, e-KerMed network already disseminated some information on several of these well, good practices and projects we have within the region. So we made the connection with the Italians as well, so as to disseminate on these good practices. If we don't have any questions for the moment, we'll continue. And so I will pass the floor to Sami. So Sami, we will let you share your PowerPoint presentation. Is it okay for you?
Yes, it is okay. Yeah.
Okay, thank you. So Sami Terala is developing manager well-being technology at the Senachiki University of Applied Sciences. And so he will present the Finnish ecosystem of innovation.
Okay,
thank you, Sami.
Okay. just a minute. I try to find my presentation.
Okay, that's okay.
Sorry. Okay. And so is it possible to share my presentation, because I cannot do it? I don't know why.
Okay, so we'll put it on the screen. Okay, we will do it. We'll do it. Just a minute, please.
Now I'm fine. Okay. Can you see it now? No.
See a blue screen? Is it yours?
Okay. Then this one.
Okay, good. We see it. That's okay.
Okay.
So you can.
Okay. Because I cannot see myself. That is. I don't know why.
That's fine. So the floor is yours.
Okay. Okay. Thank you very much about this possibilities to come to share some situation of our ecosystem in Finland. So in Finland, we have a situation that we have quite many ecosystems, and we have good cooperation with the ECH Alliance, what we heard before today, what the situation there, and actually our ministry start to support and develop this kind of thinking few years ago, and now our situation is that here is quite many ecosystems in Finland, and I have some collection what kind of ecosystems we have here, and here are some basic things about these ecosystems, but still I cannot say very much about everything what they do in ecosystems, but this is only very small presentation where we have ecosystem, what kind of organizations we have, and what are maybe the main targets, how to say. So here you can see our map. It's quite small, sorry about this, but we have ecosystems in Helsinki area, in Jyväskylä area, Kuopio area, Oulu area, Vaasa area, Pori area, and Seinäjoki area. So I think that it's almost full Finland. We have own ecosystems in all areas, and we have cooperation between ecosystems, what is very good thing. I know that there is quite many projects, and they do a lot of work in Turku area and in this eastern part of Finland area too. But I haven't no idea that do they have ecosystem. Maybe not yet. Maybe in future. But they still they develop this topic, well-being technology topic there too, as everywhere. I think. So I start Helsinki. I think that is quite a new, and our ecosystems they work different topic. Some of them are companies, and there is different background. They are projects maybe who support ecosystems and other things. But Helsinki area, there is Health Capital Helsinki organization who take care of these ecosystems, and as you see, there is quite a big organizations who are involved in these ecosystems. City of Helsinki and Espoo, they are main cities on our southern part of Finland, and of course University of Hospital, University of Helsinki, Aalto University, and University of Applied Sciences in this area are in this group. And I know that they have done several processes, and of course there is connection to companies too, but that is the main topic in Helsinki ecosystems. Central part and central part of Finland, Jyväskylä area, they have ecosystems, and Keho Finland take care of that. And Keho Finland is University of Jyväskylä organization. And as you see, there is quite many partners and members in these ecosystems, but as you said, there is similarities. So there's universities and cities and University of Applied Sciences, and then they have in Jyväskylä research organizations and companies. They are as a member in ecosystems too. So University of Eastern Finland is part of this, and this University of Eastern Finland is their main cities are Kuopio and Joensuu. Kuopio area is the next one, and as you see, University of Eastern part Finland is the ecosystem partner. Actually, there too. Ari Grön is the CEO, and that is osuuskunta. I don't know what is it in English, but it's some kind of company who take care of these ecosystems there. And they have started maybe 2 years ago, something like that. And as you see, there is universities and University of Applied Sciences, cities and enterprise organization and companies with them. I think that they are quite active in there. In Jyväskylä area, you notice that there is this sport area and this kind of things. What is one key area there, and in Kuopio area, you can see that there is that kind of there is research, development, and innovation-based customer organization and cooperation between them. Oulu is our oldest ecosystem, and there is very wide work what they have done a long time. I don't actually know how long they have been these ecosystems, but they are very good organized ecosystems, and they have research part, they are process part, and they are business part. And I think that one point why they are developed this area so strong is that they have a lot of technology companies in this area. You maybe remember company name Nokia, and before they have very much work and employees in this whole area. And nowadays, when Nokia is not anymore so big companies, very many Nokia employees have started their own business and built their own companies in this whole area, and they are part of this whole ecosystems. And we have tried to learn from them, because they have do very good work with these ecosystems in there. Vaasa area is quite a new ecosystems, and the lead organization of this ecosystem is hospital districts of Vaasa, and Tony is development manager of that organization. And as you see, the main thing is same, that there is universities, University of Applied Sciences, companies, and with these ecosystems, and quite many areas they have regional council of that our area with the ecosystems too, what is very important for ecosystems, I think. So Satakunta area, they haven't own ecosystems, not yet, I think, what is my knowledge now, but they have projects where they have started to develop this area. And they are very nearby Tampere, so they have common work with Tampere area, and they have started to do this. As you know, there in this process, what they have started to develop this thing is companies and University of Applied Sciences and University of Tampere. And in Pori area, they have done quite a long time this well-being technology work. There have been several processes. We have been common process several years ago, and they have lab where they have pilot health technology systems with companies, and that is one key area what they have done a long time. So what is our situation? So our situation is that we are start point now. We have been connection to other ecosystems from here. We have discussion. We have been some conferences together, and of course we have good connection to ECH Alliance, who work with us and with other ecosystems in Finland area, and try to find good cooperation and process and other topics what we can do together. And with this intensive process, we have been possibilities to start to think about that how we build this ecosystem in this area. My background is that I start this well-being technology area in 1999, and we had EPTEC name organization, and we had very good connection to different organizations and in this area. And now we continue this work, but we haven't built ecosystem before. But now we think about that: do we need some company? Do we need some organization who take care of these ecosystems? And now University of Applied Sciences of Seinäjoki, with intensive process and Regional Council of South Ostrobothnia have started to do this work. As you see, we have quite a good members in our intensive process and in our ecosystem, the start point, and we have good and many organizations, and we have started to discuss with them. And they are very same kind of organization as everywhere else. So that is the basic thing, I think. So in SEAMC, in our University of Applied Sciences, that is not new thing, as I told before. We have do this work quite a long time. EPTEC done this work quite a long time, so our team have done this work quite a long time. And now we go forward, and it's very important that we have other ecosystems and other partners in Finland and outside of Finland to do this work. We have membership of EIT Health Network of Living Labs and Test organization and eHealth for Regions network. And with them, we have done process and other things. And of course, ECH Alliance, what I mentioned before. So you can see our focus area, and this welfare services is one of our focus areas, very important for us. And that's why we support a lot about this ecosystem thinking and this work in our area. So of course, processes are very important to us, and that's why we try to find cooperation and organizations to find common process and international process. Horizon process would be nice to get, but it's very difficult to do that because they are so high level process. But that is our main thing what we try to do and find good partners to do this work together. So what we have in our university, And what is important point of mine is our centers. This is one example how we do this work. So we have living labs, we have different kind of centers where we pilot technology, where we teach technology, and where we test and try to learn technology. We have simulation environments. We have telemedicine lab, where is basic technology, quite a much technology was assist and use in municipalities, and we teach this technology for our students, and of course test by ourselves it. And then we have Seinäjoki Home of Wellbeing lab, where is more in future technologies. There is robotics and artificial intelligence technology and that kind of things. So I think that's very important to get these kind of places where is different kind of technology to learn and teach and pilot. So as I said before, in our intensive process, what you have heard more before today is very good support for us to do this work, and because intensive process is you have to support your regional politics. It's very important to get stakeholders in this area, in this process, and in this ecosystem building. And we have very good stakeholder group in this process, and we have people from municipalities all over our region. Then we have organization of business area and hospital area and research area. So it's good start point to do this work. Here you can see what are our topics in Seinäjoki and what we try to develop here. They are quite a basic, but still very important. Well-being in inclusive societies, smart and healthy living at home, active and healthy aging, and smart hospital of the future. These topics are important for us. So our partners in intensive process are there. I think that you know that, and it's very good cooperation to do this work together and try to find out what is situation in different area. And as we had discussed today, that we have collected 50 good practices, and it have been very interesting and good to notice that we have do same kind of work, and we have same kind of good practices, and we have noticed same kind of thing is this process, and go forward together. So here is our other topics. So this policies is important, stakeholder groups is important, good practices in product is important, and this cooperation is important in this process, and we have good possibilities to use this process to building our own ecosystems and cooperation between our areas. That is very short presentation, very short thing what is situation in Finland. I'm sorry that I haven't not so much time to share you more about the areas ecosystem, and maybe not so much knowledge about that. But what is important, I think that it's important that I can show you that in Finland we have quite a good situation, that we have ecosystems all over the Finland. We have cooperation between ecosystem. We share information between us and our knowledge between us, and we have possibilities to collect good partners to make this development work together. and of course we need partners from abroad, and we have possibilities to find with this group cooperation together. Okay, thank you.
Thank you, Sami. Thanks a lot for your presentation. That was really interesting, and you're really developing a lot of stuff in Finland. We just have one question to share with you, and then I think Gregor has some comments to make after your presentation. So we got one question, which is how do you manage intellectual property sharing within the living labs? Is it simple for you?
How I share? Could you please repeat?
Yes. How are you sharing intellectual property? How are you managing intellectual property sharing within living labs? And is it simple to manage?
Yes and no. Yes and no. So the building our centers and because there are so many centers, it have take time, and of course we have discussion how to use it and who take care and which part of this, and that is what we do all the time. So we have engineers who take care of this technology and take care of that everything works, and then our teachers they more teach, and there is another group who support this work, and that is what I'm trying to say. And I don't know if I answered your question, but that is very multi-professional work, and when we develop well-being technology, we need different kind of people. We need technical people, and we need, of course, the substance people and research, and we need this technology and places and people who take care of that, and that's interesting work, but it takes time, and it's have to find right people and right things what to do, how to say.
Can I comment this question?
Sorry.
Can I comment this particular question on the IP?
Yeah, of course.
I'll just give you an example. In my country, it's 2 million people, a little bit smaller than the region of Bhutan. We should just have 2 good lawyers for IP. Of course, many more lawyers claim that they are good, but getting to good lawyers in intellectual property, so the intellectual property is easy if you have good lawyers. If you have average lawyers who deal with everything and then you put them on IP, this will not work well. So I do recommend that you find somebody who is also very well connected with the European Patents Attorney Association, and it's basically a small circle of people who really deal well with this. And once you're in proper hands, you will be safe. Otherwise, it's a mess. So a lot of companies actually just neglect the issue of IP. So that's my experience. They don't protect, or they protect really bad, and it doesn't matter if you protect really bad. Other than that, if you have good lawyers, you can this is worth really a lot. That's my experience.
Okay. Yeah. I think the situation is not so black and white in here, but I understand your comment here.
Well, it's never black and white. I just like to paint it black and white,
Okay.
It's a rainbow. It's actually a rainbow, but I wanted to have a comment, so if that's okay.
Yeah.
I really love the way Finland entered this ecosystem network because it also happened in European presidency, basically, I think it was a year ago, if I'm not wrong. Sami, you can correct me. And suddenly, you know, we just had one ecosystem in ECH Alliance for years already. This was Ulu. So Ulu is really fantastic, you know, because largely because of Nokia, not just because of Nokia, but you know, there's a big impact of what Nokia did to the region. But now we see really high density of I would say high quality ecosystems, including yours, Sami. I'm really amazed at how Finnish people find cooperation. Now I have a question for you and also for Brittany. By the way, Anne-Claude, this was a really great presentation. I would really love to have it. I'm interested, really. I have a question for you, both of you. What is the most important thing that you will do in 2021 in your ecosystem?
I can start to answer. We will mainly focus on data management and how to develop innovations with data management and artificial intelligence and connected solutions. That's the main focus.
That's fine.
And cybersecurity, which is a high topic in Bretagne with high skills.
Okay. What about Sami?
Yes, this is a good question, and that is a question what I'm thinking quite a while of time, I would say.
So just I can also give my answer, you know. We are not good in telemedicine in Slovenia. Where is the problem? Actually, in my understanding of telemedicine, if the government doesn't, you know, create a strategy and create the top-down approach, it will not work. Because my government does not have the strategy. So you have a lot of hospitals trying, Telekom Slovenia is trying, you know, small project pilots. You have pilot after pilot, but if you don't have a top-down strategy, like, you know, we will pay this much money to create like the infrastructure, then the telemedicine doesn't work. So a great example of how telemedicine can work is the Scottish government. So Scotland said simply 5 years ago, it was very simple. They said every Scottish citizen can reach any doctor, any Scottish doctor via telemedicine. So that was the basic idea. But that is my case. So in Slovenia, we are talking to the government. Our ecosystem is talking to the government about establishment of telemedicine strategy, which includes writing of legislation. So we need to create legislation, public policy, and then create a roadmap, and it will be a long roadmap. It's not something for the next year, but we want to establish the strategy. Okay.
So the point of mine is that we need a roadmap of the first in our region, and we have been very good cooperation in process in different organizations. But now we need to find correct persons from each organization and build this ecosystem physically, and then roadmap of this ecosystem in our own region. And then we can continue with other ecosystems in abroad with you and other places in Finland. What I'm thinking. Now we do this work with intensive projects. Now we have started to think about together with our stakeholders how we go forward. But it's a long way to go forward, and now we plan this.
Okay.
Yeah.
Thank you. We have another question. Oh, sorry. No. Okay, Claude, you can react, and then we'll take the other question.
I wanted to say some words about the digital strategy in France with the Ma Santé 2022 and the Little House, and it's really a framework for the whole of France, and I think there will be quite a lot of development, and it's important for us in France, this framework.
Yes, great.
With the health data hub, with all the cooperations between private and public stakeholders to develop new services for citizens and for practitioners. So it's really a roadmap that is important for the whole regions and all of the regions in France.
Okay.
Yes, so we received one question for Sami. For all the new e-health solutions that you have, do you evaluate them by using the BigVA model to evaluate their interest?
Not all. We have evaluated BigVA model only the intensive process good practices. It's 10 good practices in our area, and we have used this BigVA model with this 10. But of course, we have been several processes before, and some process we have evaluated it. Some process we have made some research, but not all.
Thank you. Any other reactions, comments? Maybe if we have any other questions. Maybe we can also give the floor to Sana. Sana, if you want to react as the coordinator of the project.
Okay.
Hi, Sana.
Let's get the picture there as well. Hi, everyone. Yeah, my name is Sanna Inkeri, and I work as the coordinator for the intensive project, project manager for the regional council here in Finland. And well, it's been an interesting day, I can say. Thanks a lot, Adeline and Anne-Claude as well, for this study visit, and Gregor from ECH Alliance, and as well for the afternoon related to the ecosystems. It's really an interesting to see different kinds of ecosystems and how they are different from each other. Well, I was kind of amazed about how you have a lot of companies and a lot of activity in Bretagne, and but then I looked at your population as well, so it's almost as much as we have inhabitants in the whole Finland. So perhaps we're somehow in different levels there as well. But anyways, of course we kind of are all touched by this e-health and telemedicine solutions, and it's although the situation is difficult with COVID-19, it has somehow still pushed us forward with these themes, and perhaps there will be at the end some good out of this as well, hopefully so. And for the intensive project, I could say that we will continue doing our online study visits, and next we will go to Hungary, and Bannon Business Network will host our next study visit in January, maybe in February, and we will then continue getting to know each other's good practices, and then start spreading them across the partnership as well. So from my side, just thank you for a nice day and really interesting presentations. Thank you.
Thank you, Sana. And well, thanks to all of you for all the different presentations, very interesting we had today, on your involvement within the intensive project, and as well as the different stakeholders, ours and yours. And we are still going to continue to share and continue to evaluate the good practices we have. And well, that will be very interesting continuing. And Claude, if you want to say a few final words.
Oh, but thank you to all of you for the nice presentations we had today, and maybe one day in Rennes physically, it would be great for us. We would like to welcome you. So thank you to everyone.
And next time in Slovenia. Huh?
Oh yes.
I will say it to everybody because I said it before already. Slovenia is the most beautiful country in the world. Yes.
Ljubljana is very nice, yes.
Thanks to all of you, and
thank you, Adeline, for all the work you do to prepare this meeting.
My pleasure. Thank you.
Bye.
Bye-bye, everybody. Thank you.
Bye-bye. Thank you.
Thank you.
Thank you.